Jupi will.
Okay. So should we begin?
Yes, please.
Okay. So good afternoon, everyone. A warm welcome to all our distinguished speakers and chairpersons joining us today. We are very pleased and privileged that you are able to join today's program. I hope your expertise and insights will make today's program a valuable and knowledgeable one for all of us, including our participants. I'd like to begin the program by calling upon our Dr. Kanchan Sharma, who is a National Chairperson of Non-Communicable Diseases Committee, FOGSI, and who is also the today's masterclass. I request Madam to give the welcome address.
Thank you, Jupi, for those nice words. Good evening, one and all. When brilliant minds they gather together, the new light begins to shine. And when healers they unite, knowledge become divine. Today we meet not just for science but for a shared purpose, a shared heart, that is ICOG Masterclass of Non-Communicable Diseases. Very kindly has been consented for me by our FOGSI President Madam and ICG Chair Dr. Parag Pinwale to understand a woman's health in every phase and guard her from the silent rise of NCDs. I welcome our respected FOGSI and the ICOG leaders, our esteemed faculty, and each participant who has joined this journey. May today's masterclass be a spark of awareness, of learning, of inspiration to heal better, serve deeper, and care wiser. So, with warm gratitude, I welcome you one and all. Today's masterclass that has non-communicable disease focus. Especially, we have 3 sessions. In the first session, the talk is about the GDM management FIGO advice, which will be taken by myself, Dr. Kanchan Sharma. Second is the lifestyle and aging, Dr. Narendra Malhotra sir. Premature menopause and ovarian failure, Dr. Meeta Gupta, and hypertensive diseases in pregnancy by Dr. Girja Vog. The session will be chaired by our Madam Dr. Sarita Bhalerao and Dr. Vidya Dhobe. The second session is first amongst is by Dr. Komal Chavan, thyroid and the metabolic diseases in the women. And second is by Dr. Shobha Gudi, obesity and the other metabolic diseases. Dr. Ranjana Khanna will be taking alcoholic liver diseases in pregnancy and tobacco and fertility by Dr. Manjul Pandya, and this will be chaired by Dr. Pratik Tambe sir, our secretary-elect of the ICOG, Dr. Brajbala Tiwari. And the third session is on the lifestyle, public health and the prevention strategies. The topic diet, lifestyle and non-communicable diseases will be taken by Dr. Suchitra Pandit Madam. Government schemes, how can we participate, will be taken by Dr. Rajshri Katke, and this session will be chaired by Dr. Ashok Kumar and Dr. Sheila Mani Madam. So, we start our session with inauguration and the prayer of that Almighty God.
I think Dr. Sunita is also there. Yeah.
are privileged to have with us Dr. Sunita Tedulwadkar, Madam, our esteemed FOGSI President, an exceptional clinician, a dedicated academician, and a leader who brings both wisdom and warmth at every platform, a pioneer in reproductive medicine an outstanding teacher, and a charismatic leader. So, with warmth in our heart and joy in the air, we welcome you, Madam Sunita, Madam. Please give 2 words of
Thank you,
blessing.
Kanchan. Thank you, Kanchan. Thank you for your kind words. Every podcast of Kanchan always start with one Hindi में beautiful poem. You are blessed with your language skills. Anyway, you have discussed the entire program, so I don't want to take much time. Thank you, Parag, Sarita, for doing such a wonderful non-stop job. Of yesterday, I could not join for one of your program because I was in one of the WHO meeting and I could not come out. But I tried to join just to acknowledge the ICOG, the organization which is doing such a fantabulous work. And I'm sure, Sheila, I keep on watching you in every webinars now and then, and Pratik and everyone. So this is fantastic. Most importantly, you have taken the people from all across. I received phone calls from Juprika also, and every webinars or the master classes, you have different, very young, energetic, new faces you involved, and that's a beauty. एक मुझे लगता है पराग, in a managing committee we should have passed those who are chairperson, they cannot be ICOG managing committee members. We should have done that because whatever young people you have introduced, Parag and Sarita, they all are working fantabulously, very well, and they should get opportunities so our organization will grow in a real sense. Anyway, thank you so much and looking forward to meet you all in Nasik VP conference or in Delhi ICOG. Thank you. Thank you.
Thank you, Madam. We are blessed with your words of wisdom.
Thank
Thank
you.
you,
I'm in
Madam.
Delhi myself. I'm in a Delhi for one of the program, but I came out of the room. Thank you.
Thank you, Madam. Now we are honored to welcome our most beloved Dr. Parag Pinwale, sir, the chair of ICOG, an academic leader whose clarity of thoughts and commitment to education that continue to strengthen our fraternity, a guiding force for young gynecologists across the India, and someone we truly appreciate for being so humble and benign. I invite Dr. Parag sir
Thank
for
you, Dr. Kanchan.
words of
Good
the
evening,
blessings.
all. I bring greetings from ICOG, and it's indeed a pleasure to address the gathering on this occasion of Masterclass in NCD. I must thank Sunita for sparing some time. Sunita, as I always say in all the webinars, when the president herself joins, it adds a flavor and it energizes all the organizing team, the conveners, because they really appreciate your time and commitment to ICOG. Thank you. Special word of appreciation to the creators of the program today, Dr. Kanchan Sharma, who is the FOGSI committee chair for NCD, ably supported by Seema and Jupirika. Thank you for being part of this program, and you really made the program very interesting. I look forward to listening to all the esteemed speakers, and I'm sure it's going to be a good learning experience for all of us. Thank you very much.
Parag, what I noticed is Kanchan called you benign personality. वो एनसीडी में इतनी घुस गई है कि she called Parag benign personality. I loved it. That's a commitment of a chairperson. Okay, bye.
Thank you. The Suvarna madam, I think she said that
नहीं
I
है
will
नहीं
be
है
joining
नहीं है
late. She is
सुवर्ण
there.
नहीं है
She will join if she's first, she'll join later, she said, madam.
Swarna Madam is our FOGSI secretary, and I welcome her. I think when she will join, I'll again introduce her. Dr. Ashok sir, leader, past. Now he is a vice chairperson, and he is handling. He is very knowledgeable. Sir is there. I think sir is there. He is handling AICOG. I welcome sir to bless us. Sir is
So,
there.
He's not there. We can ask Dr.
So,
Sarita, and of course Dr. Sheila
Dr.
Mane is also
Sheila
here.
Mane is there.
So
Yeah, yeah, Dr.
we'll
Sheila.
request Dr. Sheila to say a few
डॉक्टर
words.
शीला माने, मैडम की जितनी तारीफ करें उतना ही कम है. शी always
Yeah.
say that
Kanchan.
succeed in your
Kanchan.
mission, you must have full healthy devotion to your goal. So everybody knows about Dr. Sheila Mane madam. She
Yeah.
is to be told as the PPH lady. Madam, I welcome you and request you to grace the occasion and bless us.
I think already Dr. Sunita and Dr. Parag has, praised for your program and your involvement as a chairperson, and I really congratulate you. And I have, as you said, today's program, you have all salvers. I think the key messages will be very, very important today. Okay. So, you have chosen the faculty, and definitely it will be very, very useful to all of us. And as we know, that NCD is very, very important today. So, congratulate you and wish you all the best. And I'll be waiting to chair myself. Okay. Thank you. See you all
Thank you.
in.
Now, two words by our ICOG secretary, Dr. Sarita madam.
Thank you, Dr. Kanchan. Yeah, I
Whose
would like to
words
congratulate.
bring of the wisdom, work bring grace, and whose quiet strength lights up every academician in space. Today's master class is an example. Thank you, madam.
Wow, thank you so much for that lovely introduction. And I think Dr. Parag has said everything. Congratulations to Dr. Kanchan for organizing this, along with Dr. Juprika and Dr. Dwivedi. And I think we have an exciting evening ahead, so I won't hold you back. We can start straight away with the scientific deliberations.
Thank you, madam, for scientific deliberation. Now I give mic again to my coordinator MOC, Dr. Jupirika. Dr. Jubirika is
Yes.
immediate past secretary of Shillong Obstetric Gynae Society. I have seen how beautifully she has arranged the Shillong conference. With this very short introduction, I give mic to her.
Okay. Thank you, ma'am, for that.
Seema Divedi is second coordinator and the MOC. She is the professor of the Medical College, GSVM, Kanpur, and holds a very good position in academics. Yes. Jupi, you can start.
Okay. So again, thank you, Kanchan ma'am, for that kind introduction. We'd like to begin the session with the first session. I'd like to call upon our chairperson, Dr. Vidya Thubi, who is a professor and former head of Department of Obs and Gynae, AMC Vijayapur. She's the Vice President-elect, FOGSI 2025. Our next chairperson, Dr. Sarita Bhalerao, madam, who's who's
I
the
think I've
secretary.
already been introduced. Don't
Yes,
worry.
madam. So, Dr. Madam, I would like to request Dr. Sarita Madam to kindly call upon the first speaker.
So it gives me great pleasure to welcome Dr. Kanchan Sharma. Dr. Kanchan Sharma is a very dynamic lady, and she's the chairperson of the NCD committee of FOGSI, and she's spoken in many conferences. She's chaired many sessions and orations, and she has also organized national conferences at Kanpur. She has publications. She has received many awards, including FOGSI Achiever Award, FOGSI UNICEF Appreciation Award, and Dr. Sadhna Desai Population Stabilization Best Society Award. So, Dr. Kanchan Sharma, over to you, and you're going to
Thank you.
speak on gestational diabetes, the FIGO advice, GDM
Yes,
management.
yes. I think my PPTs are visible, madam.
Yes, ma'am.
I am audible also. So,
Yes, ma'am.
with again thanks and gratitude to ICOG, my topic is the gestational diabetes mellitus FIGO recommendation. So, starting with the FIGO initiative on the gestational diabetes, FIGO recommends that hyperglycemia, that is a gestational diabetes mellitus, may be considered a global health priority. Hyperglycemia is one of the most common medical conditions women encounter during the pregnancy. We see that 1 in 6 live births occur to women with some form of the hyperglycemia, 84% of which are due to GDM. So, why this topic matters a lot to us? Because the India is a high prevalence zone, early diagnosis that prevents complication, and it reduces the long-term diabetic risk in mother as well as in the child. So GDM is on the rise globally. FIGO also says it. Hyperglycemia is a leading cause of the maternal mortality. There are higher incidence of maternal morbidity and higher incidence of the perinatal and the neonatal morbidity. Later long-term consequences even we can see for both mother and as well as child. Low and the middle income countries, they account for 85% of the annual global deliveries and 80% of the global diabetes burden. 90% of all the cases of maternal and the perinatal deaths and the poor pregnancy outcome that happens. So pregnancy here offers a window of opportunity to establish services, improve the health, prevent the intergenerational transmission of non-communicable diseases. FIGO recommends universal testing of all the pregnant women that should be tested for the hyperglycemia during pregnancy. It's a one-step procedure which is recommended by the FIGO. Why test during the pregnancy? Maternal and the newborn outcome depend on the maternal glycemic control. Testing is the only route to diagnose and manage. And while testing only women with the risk factor, rather if we test only women with the risk factor, we will miss half of the women with the GDM. So it accounts for long-term benefits, and outcome shows that universal testing is also cost effective. So universal testing should be done at the first contact or first visit, ANC visit. Repeat at 24 to 28 weeks, and non-fasting OGTT is acceptable here. So what is FIGO stands? It's a universal screening single step 75 gram OGTT, suitable for all the resource settings. Successful diagnosis is the best using lab result of venous plasma sample, but using a plasma calibrated handheld glucometer is also acceptable. All the countries have an obligation to implement the best testing and the management practices they can. There are 8 countries which accounts for 55% of the global live birth and the 55% of the global diabetic burden. These are India, China, Nigeria, Pakistan, Indonesia, Bangladesh, Brazil, and Mexico. So what are the diagnostic criteria? 2-hour OGTT. If the levels are equal to or more than 140, then it comes under the category of GDM. If equal to or more than 200, it comes under the category of overt diabetes. So FIGO recommends that all the countries, they should provide the best GDM management possible given available sources. So it aims at frequent follow-up, antenatal care with a GDM trained healthcare providers. Self-monitoring of the glucose for all the pregnant women with diabetes. Lifestyle management, of course, is very important. Nutritional counseling and the physical activities are key to reduce the risk of the future obesity, type 2 diabetes, and the cardiovascular diseases. Pharmacological management. If the lifestyle modification alone that fails to achieve the glucose control, then we can control it with metformin, glyburide, or insulin. So what is the management overview? Diet, exercise, SMBG, pharmacotherapy, and the fetal monitoring and delivery Medical nutrition that include 3 meals plus 2 to 3 snacks. Low glycemic index food. They should avoid sugar. 25 to 35 kilocalorie per kg per day is advised. What about the physical activity? 30 minutes per day. Post-meal walking is advised. Avoid supine exercise later in pregnancy. What are the glycemic targets? These are fasting should be less than 95 milligram per dl. 1 hour PP should be less than 140 milligram per dl, while 2 hour PP is less than 120 milligram per dl. So, amongst the pharmacotherapy, insulin is preferred, of course. Metformin if insulin is not feasible. Now, they say that avoid glyburide because it crosses the placenta and causes fetal hyperinsulinemia and macrosomia, and NICU admissions rate is increased. So fetal sonographic assessment can help to determine the size of the baby and diagnose fetal macrosomia, the most frequent complication of GDM. Baby well-being should be assessed through a simple fetal kick count technique, or when resources are available, do biophysical profile. When pregnancy with a good glycemic control is there, we can carry the pregnancy up to 40 to 41 weeks. Elective cesarean delivery may be recommended if the fetal weight that exceeds more than 400 grams. And the post-delivery, the newborn must be carefully observed for the respiratory distress and hyperglycemia. The fetal surveillance. The fetal surveillance that include at 28 to 32 weeks growth scan, repeat 36 to 37 weeks, and NST and BPP if needed. Timings of the delivery. Diet controlled, we have to deliver at 39 to 40 weeks. Insulin control at 38 to 39 weeks. Poor control at 37 weeks. Intrapartum care goals, what are they? These are keep the glucose level 70 to 110 milligram. Insulin dextrose protocol is there, and observe for the shoulder dystocia, which is most common in these babies. Postpartum management is also very important. Here, if everything is normal, blood sugar levels are normal, you should stop the medicine unless there is DIP. OGTT at 6 to 12 weeks. Annual diabetic screening is to be done. To work towards achieving sustainable development goals, given the link between the hyperglycemia in pregnancy, poor pregnancy outcome, and the future risk of diabetes in both mother and the offsprings, a focus on the prevention, screening, early diagnosis, and managing hyperglycemia in pregnancy is needed globally. That is said by the FIGO. So, FIGO recommends using the postpartum period for increased engagement to improve health for mother and the child. Postpartum aims are very important. These are early detection of infection, support of breastfeeding, advice on pregnancy spacing, retest all the women with GDM at 6 to 12 weeks of postpartum, and the future blood glucose test. Postpartum period is an important platform to initiate early preventive health for both mother and the child, who are both at higher risk of future obesity, metabolic syndrome, diabetes, hypertension, and cardiovascular disorder. So both lifestyle intervention and metformin can be effective in delaying or preventing diabetes in women with impaired glucose tolerance and a history of GDM. So aims for preconception and pregnancy intervals, this is also very important, is increase the acceptance and access to preconceptional services and universal preconceptional screening for malnutrition, anemia, overweight and obesity, hypertension, diabetes and thyroid dysfunction. That is told by FIGO. So thank you very much. Together we will shape a safer and healthier future for the women and the girls around the world. That is said by FIGO and we FOGSians as well as ICOG persons also. Thank you. I have just completed in the time. Thank you very much, Jupi. Thanks for the patient hearing. You can just take the comments of the chairpersons. Dr. Vidya Thobi, madam, is there? Kindly give your expert comments.
Madam, Dr. Sarita, Madam, Dr. Vidya.
Yeah. Dr. Kanchan, you have done very wonderful job for your topic. You have covered everything about the FIGO guidelines and all. There are no comments and no questions in the chat box. Maybe if there are any questions, please put in the chat box. You have covered the entire thing about the FIGO guidelines and all. And what I always tell every patient of gestational diabetes, medical nutrition therapy is a very important part of any treatment. So even we start the pharmacotherapy, we have to spend some time for the counseling and the telling about the calorie count and what she eats. And there is one diabetic plate. So that nutrition plate, you can explain it very nicely that what she has to eat rightly. So thank you very much. Let us move ahead.
Thank you very much, madam.
Thank you.
Jupi, you can start the
So
next session.
yeah, so
the
we'll
second
go.
topic.
We'll start.
Yeah. One question, all right. Wait, Juprika.
Yeah, how
There is
do?
a question: how to do GTT if the lady is on? You can answer even in the chat box so that we don't
We will
waste time.
answer on the chat
If the
box.
Yeah.
lady is on metformin in the first trimester.
Okay,
Okay,
I
so
think the
for the
speaker
lady who
can.
are taking
75 gram is the
metformin
universal.
and you want to do GTT, how you will do? Yes.
So
Yes, you can answer in the chat box or that will save our time. Yes.
Yes, I think Dr. Kanchan, Madam, can answer in the chat box, ma'am.
Okay.
Okay.
We will do
So we'll
the.
go on to the next speaker. I'd like to request Dr. Vidya to kindly introduce Professor Narendra
You can see on the screen Professor Dr. Narendra Malhotra, and he has got so many credentials. It is full page. I think it runs in pages. So we know him very well. He never. The topic is also very nice for him always. That is lifestyle and aging. And you can see him. He is a ever young president, past president of FOGSI, as well as he is a managing director, Global Rainbow Healthcare. We know about his all credentials. And I also feel that the aging gracefully is often used as some euphemism, and aging gracefully does not necessarily have to refer to age or appearance, but rather the attitude people have as they go through the various stages of life. So let us listen from Professor Narendra Malhotra, sir, that lifestyle and aging, how it matters, and how we can conquer our age. So over to Professor Narendra Malhotra, sir. Welcome, sir.
Share.
Start.
Masterclass today evening. I apologize. I'm not here personally, and this is a recorded because we have IAPM World Congress going on in Delhi. But I'm there open for any questions or anything which you may have, which you can put in the chat box. I congratulate ICOG. I congratulate Parag Binawala, Sarita Bhalerao, and Sheila Mane, and of course, our president, Dr. Sunita Tandulwadkar, for organizing all these master classes through ICOG, and for Dr. Kanchan for hosting this on the NCDs. Now, we know that women's health and non-communicable diseases and lifestyle and metabolic changes are very, very important. And what I'm in this 15-20 minutes going to take you through is lifestyle and aging. So getting old is mandatory, ladies and gentlemen. Feeling old is optional. And that is exactly what I'm going to take you through. Lifestyle and aging. I am, as you all know, Professor Dr. Narendra Malhotra, a senior OBGYN, past president of FOGSI from Agra. So let's see this small video which I made. And the small video shows that old age is something only the lucky ones get to do. Age is nothing but a state of mind. Keep being fun, free, and spirited. Don't worry about getting old. Worry about thinking old. Life is precious. You motivate us to make the best and most of it. Age is a matter of feeling, not a matter of years. Many years, after working so hard for many years, it's time for me to now smile with dignity, and beauty exists at any age. It's about you and your perfection. Celebrating your wisdom, strength, and love today and always. Beautiful young people are accident of nature, but beautiful old people are work of art. Live your life and forget your age. And do not regret growing old. It's a privilege which is denied to many. It will not let age change me. I will not let age. We are not old. We are just classic. So thank you very much for inviting me here to speak on it. Let me take you through aging. Now, aging is a gradual decline of physiological and cellular function. It goes beyond visible signs of wrinkles, gray hair, and it is driven by many things like genetics, like environment, and like lifestyle. So genetics, lifestyle, physiology, socioeconomic status all influence aging. Aging is in our genes. We know we have chromosomes. At the end of the chromosomes are telomeres, where all the DNA in your genetic material is coiled up. And if you have short chromosomes or short telomeres, you will age faster because your stem cells will run out and you'll not be able to repair yourself. So aging is influenced by genetics, epigenetics, which is around us, our lifestyle and our environment. And WHO defines healthy aging as maintaining functionality that enables well-being. And it's a process of cellular senescence. Cells go to sleep, telomeres shorten, there is oxidative stress. WHO also says by 2050, the population of over 60 years will double. And that's very frightening. So it's a gradual decline of your function. It is natural. So we should age gracefully with dignity, and anti-aging treatments do work, but do not try any roadside treatment. And consult a regenerative medical specialist if you need to try. There are two types of aging. One, by your number. When you were born is the years you have lived. The other is your physiological state of the body. So that is known as biological aging. And biological aging changes depending on how young you feel or how old you are. Why some people age faster? Because they have short telomeres, genetics, because they live in epigenetics, which is not good. Their environment is bad, and they are subjected to chronic diseases. Now, in the olden age, people lived in the villages, greenery was there was no pollution, everything was nice, and people lived to hundreds of years. They died of infections, but not of aging. Today, what has happened is, see the DNA in our cell, this DNA strand gets damaged because of oxidative stress, drinking, smoking, environment, pollution, fast food, all that, and our body comes and repairs it. But if the DNA damage keeps on happening repeatedly, the second DNA copy comes and again repairs it. But this can continue only till some time. If you keep on living in an environment of bad environment, then this DNA will finally not be able to repair. And if it is not able to repair, your genes get affected because of this bad environment. So ladies and gentlemen, is it possible that turning 60, I'm looking like 40 and I feel like 20? Yes, it is possible. And it was told to me that there is a fountain of youth in Italy, and if you drink water or bathe naked into it, you can become young forever. It doesn't happen. I wish it was as easy as this. What we all have to realize is that for successful aging, the clinical approaches that we need to adjust to the changes which aging brings, like your sleep-wake habits, like your bowel habits like balancing benign forgetfulness, sleep apnea, depression, hypothyroidism, gait disorders, cognitive impairment. These all will come with aging. So get adjusted to all this, and that will be unhealthy. Well, here you see the aged past presidents of FOGSI on a stage and the current president also. And that is what is required. Friends, family bonding, conference time, relaxation time, hobbies time, meditation time, exposure, nil exposure to UV. Social isolation should not be there. We should be friendly like all of this. Mental activity should be there. Good nutrition should be there. And of course, fitness and exercise should be there. So the weapons to fight aging is have a healthy mind, sleep well, relax well, have a healthy body, proper diet, proper exercise, no smoking, alcohol, a daily skincare routine, see your cosmetologist once a month at least, and your regenerative medicine specialist, and of course, a yearly complete health checkup to see you. Another small video on family bonding, and that is how aging is. All of you should be bonding with a family like this. And bonding means meeting together very frequently, going out for meals, celebrating birthdays, celebrating anniversaries, rather than taking drugs, medicines like metformin, NAD boosters, hormonal treatments, biotechnological stem cell therapies. All that helps. But if you have family bonding like this, then the health, aging, anti-aging would work much better, all the treatment. Correct diet, have a rainbow plate of greens in your plate, proper exercise, meditation, yoga, as you can see, relaxation, and a no anger sign. Our hospital has no anger zone written at all places. So even the patient gets angry, I get angry, the nurse point it out, nurse gets angry, I point it out, patients get angry, we say this is no anger zone. So that is very, very important, and that Shivani Didi from Brahma Kumaris taught us that. So the correct diet is necessary, correct physical activity is necessary, and proper sleep is necessary. What exercise? Now weight loss, if you do exercise, you'll get proper weight loss. Central obesity will go. The lean body mass will increase. The blood pressure will improve. Aerobic capacity will increase. Insulin sensitivity will increase. Bone mass will improve. Muscle strength will improve. And you will get a feeling of well-being. So exercise does it all. And that is what is required every day. Correct your microbiome. We know that good microbes leak into a gut. So your gut microbiome has to be good. Eat probiotics, prebiotics, fermented food. Avoid anything which is white, sugars, maida, white breads, all that. Reduce the stress and exercise regularly. The telomere lengthening is possible when you eat legumes, nuts, seaweed, fruits, and 100% fruit juices, sugar-free. Dairy products, coffee, and it is inversely associated with alcohol, red meat, and processed meats. Avoid all that. The foods, see, it's inflammation in our body, which damages our chromosomes and genes. And the foods which increase inflammation, there's a whole list of them, especially the fast food. The foods which decrease inflammation are dark green vegetables, amanat, spinach, blueberries, vegetables like broccoli, asparagus, beans, green tea, matcha tea, avocados, coconuts, walnuts, pista, pine nuts, almonds, cold water fishes, including salmon and sardines, turmeric, cinnamon, spices, all that should be there in your diet in adequate amount. We can also go for intermittent. It is now clinically proven that if you fast, the body chromosomes have time to repair themselves. Because you keep on eating, then there is no time left for things repair to happen. So 16 hours fasting, that means early dinner, late breakfast, for all of us, will keep us healthy. What are the future therapies for longevity? Restrict your calories. Take senolytics, NAD boosters, which are available as sprays, as powders, and NAC therapy, as even IV therapy. Focus on health span rather than lifespan. Whatever age, should be healthy. And there are some personalized anti-aging interventions. There are a whole lot of creams and cosmetics. Buy the right ones. Do not go for the cheap ones. They may damage your skin. There are a lot of herbal supplements and anti-aging supplements available like Shilajit, Ashwagandha, all that. Yes, they all help if taken right and if taken from a proper place and not a duplicate one. There are a lot of antioxidants which we should all be taking, like omega-3, like lycopene, and that melatonin. All that is healthy and can reduce aging. There's a huge part of sexual aging, and sexual aging is very, very important because that is an integral part of your health. Difficulty in having orgasms, only masturbating, urinary problems, decreased libido, sustained erections, erectile dysfunctions, premature ejaculation, all that will improve with proper diet and proper exercise. There is skin aging. There are skin treatments which are done by cosmetologists, the RF massage, the threads which can be put to tighten up your skin. Now these are temporary, and these temporary methods will make you look good, give you confidence, and then you can go ahead and maintain the others. So these it is worth trying them. There is no harm in them, but please don't do it very frequently or only depend on these. There's hyperbaric oxygen therapies. You have oxygen tents and you have oxygen rooms where high pressure oxygen on double the atmospheric pressure can improve your inflammation and body tissue, improvements of blood flows, and reduces swelling, pain, and the other things. There are a lot of ginseng, UBQR, pure M&M, NAD and NEC, which are available to be taken orally, or yes, you can take it. Whether we should be doing anti-aging or not, actually aging is fun. So enjoy it and be healthy. So let's see what in the last 2 or 3 slides and what we should be doing. So the healthy aging pathway is, first of all, the body assessment, BMI, BP, glucose, cognition. Second, identify all the modifiable risk which the couple is having or the patient is having, like the diet, activity, sleep, stress. Ask them in the history. Then give them an intervention or personalized lifestyle intervention, which is very important. Monitor the biomarkers and adjust the strategies and maintain social and emotional engagement. Very, very important, which I've been showing you in all the videos. So this chart has come a little wrong, but doesn't matter. The dietary approach, if you have Mediterranean diet, which contains olive oil, nuts, fish, fruit, cardiovascular risk is reduced, lifespan is increased. If you have DASH diet, low salt, high fruits, vegetable, hypertension is reduced. If you have caloric restriction diet, minus 25% calories, oxidative stress reduces, autophagy improves. So your body eats up all the dead and the old cells. So cellular senescence will improve. What exercise does? Assess the physical capability and comorbidity of the patient, whether they can exercise or not. Depending on that, prescribe exercise, aerobic 150 minutes a week, and resistance exercise, that means weight bearing 2 to 3 times a week. This will add flexibility by yoga, balance exercises by yoga, and monitor the heart rate and fatigue rate. All this improves the mitochondrial function and insulin sensitivity. And we know mitochondria is the battery, so it improves aging. Then look at or ask about the cognitive and emotional aging. Cognitive decline is due to inflammation, oxidative stress, synaptic loss. Cognitive engagement should be advised. Ask them to read, ask them to do puzzles, so you maintain a neuroplasty. Social connections reduces dementia. Meditation and mindfulness. Close your eyes, mind has to be evacuated, and good thoughts has to be flow. This will improve the telomere length. Then we have to ask for sleep, circadian rhythm for longevity. So 7 to 8 hours of sleep is very, very important. If you have sleep disturbances, inflammation is more, growth hormone reduces, aging occurs faster. So sleep hygiene, regular bedtime, dark room, and no screens. Social connection and longevity. If there is social isolation and the person is not social and not going to parties or mixing, mortality is 26% more in this. So these people should voluntarily engage in community activities, Beti Bachao, Beti Padhao, good diet, go to the villages, talk to the villagers, improve the health of the others, your mental and physical, you will improve. Intergenerational interactions will also foster. So interact with your children, with your grandchildren, and that will improve them and improve you also. The key biomarkers which I was saying, how do you measure it? The telomere length is measured by cellular aging and improved by exercise and meditation. The inflammation is measured by IL-6 and CRP. CRP is simple test, and it improves by diet, sleep, and stress. The fitness is measured by VO2 max, that is oxygen saturation, and this improves by aerobic training. Very simple lifestyle methods for it. So the algorithm summary is physical domain, improve exercise, diet; cognitive domain, learning and socializing; emotional domain, mindfulness and relationships; biological domain, monitor biomarkers; preventive care, do health checkups, vaccinations, screening for all. So to conclude, ladies and gentlemen, the key message is that aging is modifiable through lifestyle changes. Healthy aging requires physical, cognitive, social, emotional balance. Early intervention will let you live longer health span, not only lifespan. And there are a lot of future things which are coming in: modifications of genes, gene therapy, personalized medicine, epigenetic profile charting, regenerative medicine, multi-omics, but there is ethical levels, whether we want to just increase lifespan or we want to increase the health span. So to conclude, and the key takeaway, aging is complex, multifaceted. Understanding the mechanism of aging will help you improve health span, not lifespan. Ongoing research is critical for uncovering newer therapies, and it goes far beyond just wrinkles. It includes systemic and molecular decline. And science is advancing, which will allow more healthier and more longer lives. Remember, when your soul is full with joy, you age gracefully and you will be attractive. See here, I'm interacting with the third generation. Make them do exercise from there. Follow the 60 poses of yoga for over 60. And of course, do some muscle training regularly in 2 to 3 weeks. That's all about aging and lifestyle. Thank you very much once again. Thank you, Dr. Kanchan, for including this in the curriculum of the masterclass.
Yeah.
Okay. Okay.
Any comment with that?
Any
by the
comments from
chairpersons?
Dr. Vidya?
Yeah. Professor Narendra Malhotra is really, it is a wonderful talk, and one should all adopt all whatever he has told talk. And in a lighter vein, age is an issue of mind over matter. If you don't mind, it doesn't matter, as it is a saying of Mark Twain. So let us make our life fruitful to others. I feel that one should help daily, apart from the all strategies told by Professor Narendra Malhotra. We should adopt the lifestyle as well as the control of mind also. And the meditation and other factors, really, they're very, very helpful for changing ourselves. Thank you very much again, Dr. Kanchan and the whole ICOG team, Dr. Parag Biniwale, Dr. Sarita, and FOGSI team for bringing me as a chairperson here. I'm enjoying this whole sessions right away. And I invite now Dr. Sarita Bhalerao to introduce the next speaker.
Thank you, Dr. Malhotra. That was a lovely talk, and it's wonderful to see how you at your age are also in the gym.
Yes.
And it's very, very encouraging, I think, to all the young people. May I now invite Dr. Meeta Gupta, and she is going to speak to us. And Dr. Meeta Gupta is professor and head of department at AIMS Vijaypur in JNK, and she's the winner of the Women's Health Researcher Award. She's also been a teacher for the last 18 years with a special interest in adolescent health and high-risk pregnancies. Over to you, Dr. Meeta.
Welcome, Dr. Meeta.
Is Dr. Meeta?
Yeah, she was here.
Yes, ma'am, I'm here. Thank you so much, ma'am. Is my screen visible? I just wanted to ask.
Full screen kar dijiye.
Thank you so much. Greetings from the northern state of JNK of India, the AIMS Jammu. So in the next 15 minutes, I'm Dr. Meeta Gupta, and in the next 15 minutes, I'll be talking about primary ovarian insufficiency. At the onset, I want to thank the FOGSI President, Sunita ma'am, Kanchan ma'am, the NCD chairperson, ICOG chairperson, Parag sir, Sarita Balarao ma'am, as well as Sheila Mane ma'am for giving me this opportunity. And we will be discussing how we define premature ovarian insufficiency, what is the diagnostic criteria, the etiology, the treatment protocols, and what are the research avenues. So, to define any depletion or dysfunction of ovarian follicles with the cessation of menses before 40 years is known as primary ovarian insufficiency if it is associated with oligo or amenorrhea for a minimum of 4 months with elevated FSH levels of more than 25 international units per liter on 2 different occasions 4 weeks apart with all other normal endocrine parameters, that is normal thyroid profile as well as hyperprolactinemia. Previously, it was also known as various terminologies like premature menopause, primary ovarian failure, early ovarian failure, premature ovarian dysfunction, hypergonadic amenorrhea were also used. But as per ASHRAE, primary ovarian insufficiency is the terminology that has to be used. Its prevalence in recent years has increased to 3.5%, whereas earlier studies has quoted an incidence of about 1%. It is the WHO class 3 infertility classification, that is hypergonadotropic hypogonadism. It is characterized by menstrual disorders like amenorrhea or oligomenorrhea with raised gonadotropins of more than 25 international units per liter and low estradiol levels, that is less than 50 picogram per ml. So, to look at the etiological classification, it could be genetic, iatrogenic, autoimmune, idiopathic, and in idiopathic, we have to consider the environmental and infectious causes, especially the viral infections. So, the risk factors of premature ovarian insufficiency or POI are genetic, chemotherapy, radiation, surgery involving ovaries, autoimmune disorders, epigenetics modification, infectious factors, environmental toxins, unhealthy lifestyles, and also chronic stress. These are all the risk factors which lead to POI. If you look at the latest study, it is said that the monogenic cause of POI is CGG triplet, which leads to expression in FMR1, that is known as FNR1 premutation. But how this premutation causes POI is still under evaluation. Several autoimmune disorders, such as Addison's disease, Hashimoto's thyroiditis, Graves' disease, and SLE, are also associated with premature ovarian insufficiency. So, how do we diagnose these patients? Any female less than 40 years who presents with symptoms of irregular cycles, a negative serum beta HCG level, also history of hot flushes which may or may not be present. We have to investigate these patients with TSH, thyroid stimulating hormone levels, prolactin, FSH, and estradiol levels. If the thyroid and prolactin levels are abnormal, then the patient has to be evaluated accordingly and treated, and it rules out premature ovarian insufficiency. But if the thyroid and prolactin levels are normal, then we have to look for FSH and estradiol levels. If FSH is high and estradiol is low, then the patient has premature ovarian insufficiency, and a repeat test of FSH and estradiol has to be done after 1 month to confirm. The patient may have high FSH and high estradiol level. In this, very rarely we may have a possibility of a gonadotrop secreting pituitary adenoma in a premenopausal patient, but it is very rare. Likewise, The third possibility is a low to normal FSH with low to normal estradiol. In this, we have to differentiate the POI with hypogonadic hypogonadism. So, an initial evaluation in these patients would be a menstrual irregularity, that is oligo or amenorrhea, for a minimum of 4 consecutive months. Then an FSH and estradiol levels have to be done, 2 random samples at least 1 month apart. Prolactin and thyroid function test have to be documented, which will be within the normal limits. AMH is not the first line of, or is not to be documented in these patients to diagnose POI. So the algorithm says that any patients having these symptomatology of disorders menses with elevated FSH, then we have to ask the history of any bilateral oophorectomy or previous chemotherapy, pelvic radiotherapy, or pelvic or ovarian surgery. In case the symptoms or the history is present, we can easily diagnose the patient to be having iatrogenic premature ovarian insufficiency. But if there is no history of these surgical or chemotherapy or radiotherapy, then after counseling and informed consent, the patient has to be offered genetic test, especially for chromosomal analysis and PMR1 pre-mutation testing, that is for Fragile X syndrome gene testing. Additionally, NGS may also be offered. If these tests come abnormally, so we can easily diagnose POI with genetic causes, and the patient has to be referred for genetic counseling. The patient also has to be made aware that all the female relatives, first degree relatives, have to be counseled or have to be investigated of POI in the female relatives. In case the genetic counseling comes out to be normal, then the autoimmune test antibodies has to be done, especially screening for 21 hydroxy autoantibodies. TSH screening has to be done, even though thyroid TSH peroxidase antibodies are not to be done. Additionally, other autoimmune diseases like Addison's disease, Hashimoto's disease, Graves' disease, and SLE also have to be ruled out. In case the autoantibodies come out to be positive, we can diagnose the patient to be having POI with autoimmune causes and likewise may be referred for further testing. But in case none of the surgical or chemotherapy or radiation history is there, no genetic test comes out to be abnormal, neither do the autoimmune tests come out to be negative, then we diagnose these patients to be having an idiopathic premature ovarian insufficiency. So after diagnosis, we know that these follicles will undergo increase or accelerated rate of atresia, leading to increased cardiovascular risk, decreased bone mineral density, urogenital atrophy, mood disorders, sexual dysfunction, a decrease in cognitive decline, causing an impaired quality of life of the patient. So the symptoms could be varied, but it is very similar to the 7 dwarfs of menopause that we say is itchy, bitchy, sweaty, sleepy, bloated, forgetful, and a psycho female. So the symptoms could have vary from menopausal symptoms, infertility, cognitive and emotional health, bone diseases, especially osteoporosis, and metabolic and cardiovascular diseases. The symptoms are very varied because sometimes the patient may not experience any symptom of ovarian insufficiency, especially in females who present with primary amenorrhea like in Turner syndrome. The symptoms may vary in severity depending upon what is the cause of POI, as well as sometimes the symptoms may intermittently disappear due to the fluctuating ovarian function. But the POI symptoms vary from mood swings to dry eyes, cold intolerance, and very simple like tingling in limbs. So, once the patient has menopausal symptoms, we also have to remember the long-term sequelae associated, that is accelerated cognitive impairment, accelerated cardiovascular disease, especially for autoimmune disorders for adrenal and thyroid, infertility, osteoporosis, and ultimately premature mortality in these patients. So, how do we manage these patients? It requires a multidisciplinary approach. Hormone replacement therapy is the mainstay of treatment. Psychological support is most important after diagnosis in these patients, and they have to be emphasized to adopt a healthy lifestyle, especially including weight bearing exercises and healthy diet, avoid smoking and alcohol to maintain a normal body weight to optimize their health in their remaining life. So, the management has two entities: maintain healthy lifestyle and hormone therapy. To maintain healthy lifestyle, patient has to be emphasized the role of weight bearing exercises to avoid smoking and alcohol, maintain normal body weight, have a balanced diet, especially with reference to calcium, vitamin D, and other dietary supplements. For hormone therapy, estrogen has to be offered to all women diagnosed with premature ovarian insufficiency unless contraindicated. The route and the method of estrogen may be as per the patient's requirement or patient's reference, and we will be talking further about HRT. After initial diagnosis, bone mineral density, especially DEXA scan, has to be done in these patients. So, we have varied treatment options available, of which HRT is the most important. There are other treatment options like stem cell therapy, exomes therapy, melatonin, traditional Chinese medicines, in vitro activation, platelet rich plasma therapy, ovarian tissue cryopreservation and transplant therapy, tissue engineering techniques, but they are all some in research stages. Coming to hormone therapy, please remember that each of these women has to be offered estrogen therapy, and this therapy has to be continued till the usual age of menopause, and this has to be given to the offered to the patient even if the patient does not experience any symptoms of estrogen deficiency. The route could be oral or transdermal, which is preferred in obese patient, or sometimes vaginal transvaginal estradiol may also be given. If the patient has uterus intact, then addition of progesterone, either cyclical, sequential, may has to be offered to prevent against endometrial hyperplasia. Females presenting with Turner syndrome have to be offered HRT from the very start of their diagnosis, and this hormone therapy has to be continued till the normal age of menopause is reached in these females. So, we have already discussed that estrogen has to be offered, and the progesterone could be either continuous or sequential. It is as per the choice of the patient. So, if the patient want fertility options, they have to be made to understand that about sometimes 5 to 10% chances of spontaneous pregnancy are also available. I will be just finishing in another 3 minutes. But oocyte donation is the most successful treatment, especially in women desiring of pregnancy. IVF with donor oocyte should be preferred, and there are other emerging therapies like platelet-rich plasma stem cells therapy, which are still under research. But we have to understand that no intervention have been shown to be reliably shown to increase ovarian activity and spontaneous natural conception rates. In vitro activation of follicle growth in biopsied ovarian tissues has been tried. There is administration of mesenchymal stem cells, specially derived from bone marrow, placenta, and umbilical cord, as well as injection of platelet-rich plasma into the ovaries have been tried. So long-term is bone loss, especially has to be looked into. These patients have to undergo DEXA scan at the time of diagnosis, and this DEXA has to be repeated every 5 years. They have to be recommended to take vitamin D and calcium, and especially a patient may have to use biphosphonates, but it is not usually recommended. A cardiovascular disease lookout has to be taken care of, especially by adopting a healthy lifestyle. They have to measure their annual blood pressure and weight loss, and lipid profile may be recommended after 5 years. Endocrine, especially hypothyroidism, has to be looked out, and these have to be documented usually once in 5 years. They may have a chance of developing adrenal insufficiency. POI, please remember, is a silent grief, and so psychological social functioning has to be taken care of. Genitourinary symptoms, in case the patient they have to be offered vaginal estrogen. If it is not fully relieved, systemic hormone Hormone therapy has to be given. Vaginal lubricants and moisturizers may also be used. Counseling and patient support is foremost important because they are under a lot of stress and it is something very abnormal in there and cessation of menses in less than 40. So they have to be guided for reproductive as well as long term health monitoring. So, to summarize, if any patient has amenorrhea more than 4 months with increased FSH levels of 25 on two different occasions more than 4 weeks apart, you have ruled out thyroid, prolactin, and pregnancy. It confirms premature ovarian insufficiency. After diagnosis, fertility options have to be given. HRT, if not contraindicated, is the mainstay, and long term follow up of bone, cardiovascular, and psychosocial care has to be given. So, this we have already discussed that these patients have to be educated for renal function and liver function, annual investigations, bone density, vitamin D levels, fasting lipid profile, and especially screening for diabetic profile has to be taken care of. So, the hormone therapy has to be given till the usual age of menopause. Annual clinical review of hypertension, cardiovascular disease, and bone health has to be given. Psychological support has to be reinforced, and bone density has to be evaluated every 1 to 5 years. Lipid, diabetes screening, and thyroid as per indicated. So please understand, POI is the end result of many processes, but the cause is usually unknown. Women with POI require an individualized treatment plan. Long term follow up is required to monitor well being and various comorbidities. Thank you.
So excellent, Dr. Meeta. So I need chairperson's expert comment.
It was an excellent talk, Dr. Meeta, and you have covered all the aspects of primary ovarian insufficiency. And what we are bothered about the comorbidities which are associated with the premature this primary ovarian insufficiency. Apart from osteoporosis, the treatment of risk of heart disease, then hypothyroidism, and mainly the other autoimmune diseases also are on the rise. And we are really worried about the emotional health of such women. I remember in my OPD, one patient, when it was diagnosed, she was so much shocked and confused. And then we have to treat that emotional aspect also. The long-term treatment like HRT to be continued till her age of menopause, that has to be there, and we have to screen for the osteoporosis and other diseases. But the emotional health also is at stake, and we have to take care of this emotional health. Thank you very much again, Dr. Meeta, for the excellent talk.
Thank you, ma'am.
Hi. Okay, so we've come to the end of this session. Why? Because Dr. Girija Wag madam will not be able to join us at present. For her session, for her topic, Dr. Parag Biniwale sir will take the session in the middle. I mean, now he's in a meeting, so we'll continue with the talk anytime whenever he joins us. So now I'd like to go to session 2.
Yeah. Before that, Jupirika, I must thank the whole ICOG chairperson, Dr. Parag Binimale, Dr. Sheila Mane, Dr. Sarita Bhalerao, and all the Dr. Kanchan Sharma and all the team who have brought out and they have carved this whole session very beautifully. Thank you very much.
Thank you, madam, for gracing the
Thank you,
occasion.
madam.
Thank you.
very
We are
much.
blessed.
So if any queries and everything, all the participants can just put their queries in the chat box and the speakers can answer them accordingly. Thank you. So we'll go to session 2. We'd like to invite our chairperson. First chairperson is Dr. Pratik Tambe, who is a Secretary ICOG 2627. He's a recipient of various awards and prizes and is also the editor of various books, has contributed to many chapters, and also he's a well-known person. I think he has already spoken at the beginning, so we'll go ahead and we'll call, yeah.
Very
Pratik Tambe
happy.
sir, we'll go on with the
Always
next.
remain happy and always very good academician, I can say.
So we'll go to the next chairperson, who is Dr. Brajabala Tiwari, ma'am. She is consultant, obs and gynae, And also she's the president of Indoor Obs and Gynae Society 2023
In her line, she is a chairperson of
and
Sorry.
chairperson.
environmental level. Welcome, Ritwala.
Welcome, madam. So I'd like to request madam to kindly introduce our, I'd like to madam to kindly introduce our first speaker.
Thank you,
Over to
Jupika,
you.
for kind introduction. And it's my privilege to be part of this important ICOG masterclass. And my sincere thanks to Dr. Parag sir, Dr. Sarita madam, and Dr. Kanchan Sharma, and all organizing team. And it's my privilege to introduce none other than very favorite Komal Chauhan ma'am. She is President FOGSI, Vice President FOGSI 2025, and past chairperson a medical disorder in pregnancy, very active academician, and she doesn't need any introduction. She had been awarded many times, and in FOGSI, N.A. Pandit and Shalja Pandit Award, Dheera Award, Mehru Hansoti Award, FOGSI Appreciation Award for valuable services, and so many. And she's always helping every time whenever we need her, and a great academician, and so many publication goes to her credit, and many talks, and always helping. So over to you, Dr. Komal.
Thank you so much, Dr. Brijbala. You're always very sweet and very charming. And thank you, chairpersons, Dr. Brijbala and Dr. Pratik Tambe. At
Thank
the
you.
outset, I would like to thank Dr. Parag Baniwala, Dr. Sarita Bhalerao, and the entire team of ICOG, and also accolades to Kanchan Sharma, our NCD committee chair.
Thank
She's
you,
doing
madam.
fabulous work with Dr. Seema Divedi and Juprika, very well formulated and very well nicely outlined a concise talk on NCD. NCD is a subject which is very close to me. And the talk given to me was thyroid and metabolic disorders. And to do justice to thyroid, I have covered everything related to thyroid in my talk. And so I would start with my talk. Over to the team, Shreya. Can you start the talk?
Yes, ma'am.
Share my slides. I'm there on the way. So I will begin with the talk.
Right.
So topic which I'm going to talk today is on thyroid disorders in pregnancy. And when we talk about thyroid, we think of all the T's of thyroid, maybe from the feeling tired to thankless to troublesome to even sometimes even tough and tense. Before I begin with the talk, let me talk about this interesting story of a tadpole. This is a tadpole. And here when the biologist was studying about the tadpole, and they found that in absence of thyroid gland, the tadpole continued to grow from this B size to a A size. It grew to a size, but it never became developed as a frog. That is the thing when thyroid will not make you develop to your full capacity. So importance of thyroid gland, iodine in certain areas, leading to poor growth, having an impact on the fetal development and cognitive behavior is all well known by everybody. And when thyroid disorders affect in pregnancy, we are basically looking at the hypothyroidism, the subclinical or the overt, either the hypothyroidism, the Graves' disease, thyroid storm, and also the postpartum period, thyroiditis and thyroid tumors. So we will be talking about all these. Before we begin, it is very important to know the physiological changes of the TBG, that is thyroxine binding globulin. And entire thyroid physiology is depending on the hormone because it increases in response to estrogen, and also half-life increases in 15 minutes to almost 3 days. And then there is an increase in the thyroid stimulating factors because of the HCG. Also the pregnancy, the BMR also increases, and all that will contribute to the changes in the thyroid profile. Additionally, the fetal thyroid begins secreting iodine at 10 to 12 weeks, and it is controlled by the fetal pituitary. At 20 weeks, it is almost taken up. So these physiological changes which we see are normal during pregnancy. That in pregnancy, almost the TSH, the free T4, T3, T3 may be slightly increased, but less, there is no change. There will be only the total T4 may increase, but in a hyperthyroidism, what we classically see that TSH decreases, and there can be increase in the free T4 and the free thyroxine index. And hypothyroidism, there is an increase in TSH. This chart shows these things when we check in pregnancy, and when patient comes with a thyroid report to us, these things are physiological and they are normal. Also, the 5 factors which altered this thyroid function is the transient increase in the HCG, which we discussed, estrogen-induced increase in the TBG, alteration in the immune system onset, exacerbation, or amelioration of the underlying autoimmune thyroid disease, increased thyroid hormone metabolism by placenta, and increase in the urinary iodide excretion. So all that factors we also have to remember in pregnancy. So because of all that, all the societies, including FOGSI, ATA, ETA, all have formulated guidelines. And by that guidelines, according to their region, they have their cutoffs. And in India, we have 2.5 in the first trimester, 3 in the second, and 3 in the third as a cutoff, which is almost similar to the European guidelines. American guidelines usually go according to their reference range in their population and for being somewhat normal for those population. So we know the guidelines, we know everything. So what about the screening? Should we screen every pregnant woman or it should be a high risk based screening? So there are so many guidelines which talk about it, right from the ACOG, the NICE guidelines, the Australian guidelines, the American thyroid and British and everywhere. But what we follow is our FOGSI, and it recommends universal screening of all pregnant women in the first visit itself. So by our guidelines, when we screen and we find out that the TSH level is above 5, we know that we are dealing with hypothyroidism. And here we also need to find out whether the patient fits into an overt disease or a subclinical hypothyroidism. And how do we know it? Overt would be when the levels become more than 10, and subclinical it will be between 2.5 to 10. So very, very clear that we know what we are dealing with. And why do we know it? Because of the effects, the maternal effects, right from the anemia, preeclampsia, placental abnormalities, PPH, and low birth weight infants, cognitive, neurological development, and neonate also having hyperbilirubinemia and respiratory distress. All are very important. That is the reason finding out the hypothyroidism in pregnancy and also early diagnosing it is very, very important. So these are the risk factors for early diagnosis, but here we do universal screening. But specifically, we should have a high antenna of suspicion when we have certain places where they come into geographical locations, or obese patients with BMI, or previous thyroid surgeries, somebody having even the family history of first degree relative, a mental retardation, or a prior pregnancy history of having a recurrent miscarriage, preterm, IUFD, eclampsia, abruption, infertility, autoimmune disorders, or any radiological dry or drug intake. So here we need to be a little extra cautious in checking out the thyroid levels and monitoring it in the pregnancy. So now coming to the management, and this is by the FOGSI 2019 recommendations. And once you find out when the patient has an hypothyroidism, you find out whether it is a overt or subclinical. So if it is an overt hypothyroidism and the TSH is more than 2.5 and you feel it is an overt, then you start levothyroxine 1.6 to 2 microgram per kg per day and maintain the thyroid level, and you also monitor it every 6 weekly to 4 weekly and keep the patient under check. But if it is between 2.5 to 10 and you're thinking about a subclinical hypothyroidism, what you do is a TPO-A antibody titer. And if you feel that the TPO antibody titer is positive, you will have to treat it as an overt hypothyroidism. And if it is negative, then clinically you can judge and you can keep the patient under observation. So what happens when you start them on the drug and if the dose is missed and the patient remembers that she remembers a little late, but if she remembers in the same day, she can just take it, not eat anything for the next half an hour. And if she misses complete a day, she should take the double the dose the next morning. And the complete bottle comes in various dosage. So you can see if the patient is taking the current dose and she becomes pregnant with the drug of levothyroxine, she needs to just increase by 25. Very, very important. But any trimester, maybe even a first or second, just increase by 25 because this dose adjustment needs to be done for the patients who are already on their treatment. So now coming to this beautiful chart, this will explain to you the entire approach. How do we go about when we do our TSH levels? and what are the role of the TPO antibodies. So whenever we get a patient, we do a TSH level, and if we get a level below 2.5 and very low levels, yes, it is thyroid toxicosis. So we will discuss it later. Once it comes 0.1 to 2.5, it is actually normal range. So we don't have to worry in this range. When we get it above 10, we know it is hypothyroidism, directly initiate treatment. But when we get a level between 2.5 to 10, how do we know that the patient is hypothyroidism? Subclinical or covert, that is on the basis of TPO antibodies. And here, even if the levels are low, around 2.5, but if you find the TPO antibodies positive, we need to treat it. But if they are negative, then we will have to find out whether it is on the lower side or on the higher side. You know, if it's on lower side and it is negative, around 2.5, little above, we don't have to do any treatment. But it is on the higher side and you feel that there may be a doubt, then you can consider treatment. It is not like compulsory, but you can individualize and you need to consider treatment with levothyroxine. So this drug needs to be continued throughout the pregnancy. But what happens during post-delivery? The patient should be reverted back to the pre-pregnant dosage and the TSH level should be checked after 6 weeks. So this is very, very important. And if some patients whom the dosage are very, very low, such candidates will not require any drug. We can just stop it and you can just observe after 6 weeks. And women with thyroid autoimmunity actually needs an annual monitoring also because they may have long-term hypothyroidism. Then coming to the hyperthyroidism, 2.5% of pregnancies. And nowadays I am seeing patients in my clinical practice with hypothyroidism. And sometimes when we over-treat also, they come with hyperthyroidism. So we need to be really cautious. So you should look for these signs: nervousness, tremor, tachycardia, goiter, weight loss, palpitations, and peritibial myxedema and some lid retraction. The eyes are not looking normal. And why are we worried? Because of the fetal problem. Yes, miscarriage, IUGR, placental abruption, neonatal thyrotoxicosis are there, including prematurity. But maternal preeclampsia, thyroid storm, and a high output cardiac failure, we are really worried about it. Treatment options, we have two anti-thyroid drugs, that is propylthiouracil and carbamazepine. Both are equally effective, both process the placenta. Now, what is there? We are worried about carbimazepine embryopathy versus propylthiouracil hepatotoxicity. So we know both are toxic, but we really need to know when to give what. So you can do propylthiouracil in the first trimester because we are worried about the birth defects. And then you switch over to carbamazepine because the organ development has happened. You keep the free T4 to the upper end of the reference range, and even a short-term beta blocker, if you use, it's fine. Because even if you have to do surgery for these cases, you need to do in the second trimester, and radioactive iodine is absolutely contraindicated. So you have limited option. You need to juggle between drugs. And how do you do this? You monitor the TFTs every monthly, and you check also for the antibody titer. You aim for the lowest possible dose, and then you can target and try monitoring and check the reference levels. And there is a risk of relapse postpartum. So you need to continue with postpartum and breastfeeding. Also, you will have to counsel the patient. The low dose needs to be given as it is sometimes even seen in the breast milk. So you should give this drug post-feed, encourage patients to have it. Now coming to the monitoring, the monitoring and shifting over, how do we do? Patient is newly diagnosed and you are now shifting from methimazole to propylthiouracil. How will you do? So methimazole 5 to 10 or propylthiouracil 100 to 200, these are the dosage which we give it. And so when we giving this dosage and you're monitoring it, you monitor it every 1 to 2 weeks. You will be monitoring the thyroid levels, the free T4, TSH, all the levels, till the patient clinically becomes euthyroid. And you will be continuing this monitoring even postpartum. So coming to the dosage, you should always try to shift the dosage at the ratio of 1:20, what I said. So here, when we are giving methimazobal 5, you will start propylthiouracil 50. So this is how, if you know that 1:20 ratio, and so switching over becomes very, very easier. But you will keep the check on the liver function test. They are very, very important, as you have to target, because pregnancy with again a liver problem will be again a problematic. So these are the side effects which we experience with all the drugs. Both the drugs comes, but if you properly use it, you can nullify the side effects or the unwanted side effects of these drugs. So a patient needs to be counseled about all these effects which they may see it, and if they are minor, we can actually just treat it by counseling. Then coming to the thyroid storm. Thyroid storm is a severe emergency hypermetabolic state. And here patient manifests with hyperthyroidism, neuropsychiatric symptoms like restlessness, altered mental status, and seizures. And it becomes a medical emergency. So we need to find out the derangement and treat the underlying the fetal effects also. So the initial therapy, what we give by ACOG practice bulletin, is propylthiouracil 1000 mg loaded by mouth, then 200 mg by mouth every 6 hours. Iodine administration 1 to 2 hours after propylthiouracil, that is sodium iodide or potassium iodide or even Lugol solution. And lithium can be given, lithium carbonate, if patients has an iodine anaphylaxis, that is 300 mg by mouth every 6 hours. So this becomes a medical emergency and it needs to be prioritized and monitored. At times, you would require dexamethasone or hydrocortisone also. And if there is a lot of tachycardia, propranolol, labetalol needs to be given. And the patients needs to be very cautious because it can be a risk of heart failure. Supportive measures such as temperature control will be needed because the temperature just shoots up in these catastrophic events. Then coming to the postpartum thyroiditis, and this is completely a postpartum phenomenon caused by destruction of thyroid, and there is a painless thyroiditis, and it is considered as a variant of an autoimmune condition and also called as Hashimoto's thyroiditis. And it was widespread globally. Around 1 to 17% women will have these kind of problem, which comes suddenly postpartum. You sometimes there is a previous history of postpartum thyroiditis and also even type 1 diabetes. So what are the symptoms? Decreased milk secretion, painless goiter, patient complains of a lot of hair loss, fatigue, anxiety, depression, mood changes. But classically, what symptom we find, like what I have seen, is decreased milk. The patient will not be able to secrete milk, and they are cut off. They are very, very cut off and very behave less in mood. So this is postpartum thyroiditis. So the pathophysiology is the initial thyroid inflammation, damages to the follicle. There is an unregulated release, large amount of T4, T3 into the circulation, and the thyroid follicles, they get exhausted, and then later on they regenerate also because of the thyroid hormone synthesis. And then slowly the thyroid secretion becomes normal. So it takes a while for these changes. It is not very sudden, and there are phases which it goes. So transient hyperthyroidism is the first phase, transient hypo is the second, and transient hyper followed by hypo, and then recovery is the third phase. So recovery is a key, but it can take almost a very long time, even a year also from postpartum. So this patient needs monitoring. And when we talk about this phases, the initial, how do we distinguish? That is hypothyrotoxicosis phase will be for 1 to 4 months, and hypothyroidism for the next 4 to 8 months. So almost 1 year is gone. And the management also is different depending upon the symptoms which the patient will have. Maybe beta blockers will be required in thyrotoxicosis phase and thyroxine in the hypothyroidism phase. And 30% chance of even having permanent hypothyroidism. And postpartum depression associated with it is very, very common. The patient will be depressed. So when there is a patient having a depression, you can get these levels and you can diagnose the postpartum thyroiditis. So also the Graves' disease and postpartum thyroiditis, there are so similarities. So what happens, sometimes you feel that patient comes postpartum, but postpartum thyroiditis is usually very, very early, like within the first 3 months, whereas the Graves' disease is after 6 months. And the signs and symptoms also vary of the postpartum thyroiditis and the Graves' disease. That is there will be milder symptoms in postpartum thyroiditis with no ophthalmopathy, but your ophthalmopathy will be very classical in the Graves, those eyes. And laboratory, your T4 will be more than T3 and your T3 will be more than T4. And when we talk about the thyroid receptor antibody, it will be elevated in Graves' disease. So this is the 2017 guidelines of the ATA for management of the thyrotoxic phase of PPT. And what they use is that the beta blockers, classically used here, anti-thyroid drugs are usually not recommended for treatment in the thyrotoxic toxic phase, because this is a classical beta blocker phase. And then later on, we require those anti-thyroid drugs. And 4 to 6 weeks, we need to monitor. And then coming to the hypothyroid phase, here you will require your thyroid medications, and the TSH monitoring check needs to be done. And lactating mothers, usually who are there, they need to be counseled also regarding contraception, because that is also very, very important aspect. Then touching on the thyroid tumors in pregnancy, yes, pregnancy thyroid tumors, not very common, but there are some patients whom you can have an incidental finding of thyroid tumor. Or there are some patients who are on a suppressive T4 therapy for thyroid cancer before pregnancy, and they continue and they become pregnant. So they should continue with the therapy, adjust the dose of levothyroxine. So you keep the serum TSH level normal in the normal reference range. But what is most important is pregnancy, and they may go on smoothly, but later on when they deliver, they may be having irregular menses, and 27% of these patients have reported, and even early menopause in this patient. So this patient needs to be counseled that it may be related to your thyroid functions, and thyroxine kinase inhibitors are generally contraindicated during pregnancy. So we need to be really choosy, and these are the patients whom you encounter, you should take a help of your endocrinologist. But I think rest of the thyroid pathology, we as gynecologists really can manage beautifully, and we are doing it with the guidelines. We are diagnosing it early. We're trying to identify the real cases, treat them, follow up them, and also counsel them for their later lives. So the take-home message are: the physiology of pregnancy alters the course of most of the endocrine disorders, and especially the thyroid disorders. Index of suspicion, it should be very, very high, because pregnancy and other symptoms may overlap, and we need to diagnose it early, because we really don't want any fetal problem, any intrauterine growth problem, or any neonatal problem, and also in long-term problem to the baby. So thyroid screening is a must. With that note, I end with slide, which I really like to portray after my talk. That is the 7 dwarfs of thyroid disorders, and they all dwarfs fit into the one pathology of thyroid, maybe right from being sleepy, achy, duggy, puffy, fraggly, and everything. So thank you so much for your patience.
Excellent talk, Komal madam. This include each and every aspect, and very exhaustive talk.
I know there was a little bit, because it was a very lengthy talk, and that is the reason it was little forwarded, little made fast forward. So I think people felt it, but I will share the talk. I will share it if anybody wants it. They can put a message to me, but it was clear that was there. Only thing, it was little forwarded and made to fit into our timings. Thank you so much.
Thank you so much.
Thank you.
While traveling, even then you covered it. Thank you so much. Dr.
You
Vidya Devi
covered
madam,
everything.
your expert comment. Expert comment
Expert comment from the chairperson.
Dr. Komal, you covered everything: hypo, hyper, thyroiditis, and even postpartum thyroid disorder. And we have to follow up to 1 year, and how frequently we have to monitor. And particularly in Indian scenario, we are finding a lot many subclinical hypothyroidism, and they remain undetected. So it is needed to do universal screening during first trimester and follow-up screening also. So that was the message given by you. And once, whenever they miss the tablet, they have to take in the daytime even. So that was a clear message by you. Thank you so much.
Thank you, Brajbala. Pratik sir?
Pratik sir,
I think it was an excellent talk by Komal. Thank you very much, Dr. Komal, for being with us and for making sure that all the extensive preparations that you had made were conveyed in the appropriate time. And I see that there are demands from the audience to actually share your talk as well. So congratulations. Well done. Let's go ahead with the next talk.
Okay, so
thank you so much.
Okay, thank you, ma'am. Next, Dr. Shobha Goody, madam, will not be able to join us immediately.
She will join, but she is on the way after Dr. Ranjana Khanna, madam.
So after that, so we'll go ahead with Dr. Ranjana Khanna first, and then Dr. Shobha Goody will join us later on. For that, I'll like to request Dr. Pratik Tambe sir to kindly introduce our speaker, Dr. Ranjana Khanna.
Dr. Ranjana Khanna ma'am is well known to all of us. She is a past vice president of FOGSI. She served as the president of the Allahabad OBGYN Society. And she has previously also been a FOGSI chairperson, organized excellent conferences at Prayagraj. We look forward to her contributions in this CME as well. And she's going to be talking to us on alcoholic liver disease in pregnancy. Currently, of course, she serves as a governing council member of ICOG as well. Over to Dr. Anjana Khanna.
Yeah, I'll just share my slide. Can you, yeah. Is that okay?
Yes, ma'am. Perfect. Please go ahead.
Okay. Very good evening. At the outset, thank you, Kanchan, for the invite, and thank you, Parag and Sarita, and thanks for the introduction, Pratik. Now I'll start with alcoholic liver disease in pregnancy. So when you drink alcohol, your unborn child drinks it too. Alcohol use disorder affects 1 in 10 women of childbearing age. Women are highly susceptible to the toxic effects of alcohol because of decreased gastric metabolism of alcohol, higher blood concentration because of lower effective circulating volume, and increased inflammatory response. Increasing number of pregnant patients of alcoholic liver disease are being encountered nowadays in India because of increasing incidence of alcohol usage in young adolescent girls. So burden of the disease attributable to alcohol in India, it's 1 to 1.9%. Ethyl alcohol is a potent and prevalent teratogen. It is one of the most common non-genetic cause of mental retardation and leading cause of preventable birth defects in the United States. What do you mean by alcohol liver disease? This term encompasses the liver manifestations of alcohol overconsumption, fatty liver, that is deposition of fat in the liver, then alcoholic hepatitis, that is the hepatocytes become inflamed, and with liver cirrhosis, that is the end stage disease, there is cirrhosis in all the hepatocytes, there's fibrosis, and the whole liver gets shrunken. So, this represents the oldest form of liver injury known to mankind. In early stages, many people do not experience any symptoms at all. This is a diagrammatic representation. On the left side, we have a healthy liver, and then we have the fatty liver where fat gets deposited, and then alcohol hepatitis where the hepatocytes get inflamed, and lastly, we have the cirrhotic liver. So this is the healthy liver. Now, when there's exposure to alcohol, then it can lead to fatty change in the liver. And when there is further exposure, then it leads to hepatitis, leading to liver cell necrosis, inflammation, Mallory bodies are there, fatty changes are there. Now, these two stages, if there is complete abstinence from alcohol, we can revert back to the healthy liver. But if the liver gets continuous exposure to alcohol, it leads to cirrhosis of the liver, there's fibrosis, and this is the terminal stage, and this is not reversible. So how much alcohol can cause damage? Consuming 60 to 80 grams per day for 20 years in men and 20 grams per day for women increases the risk of liver damage. Women have double the risk of getting alcoholic liver disease than men. 80% of the alcohol passes through the liver to be detoxified. Chronic consumption leads to secretion of pro-inflammatory cytokines, oxidative stress, lipid peroxidation, and acetaldehyde toxicity. Risk factors. Quantity of alcohol intake we have talked about. Pattern of drinking outside meal times increases the risk of alcohol liver disease up to 3 times. Women are twice as susceptible than men. Hepatitis C infection, a concomitant hepatitis C infection accelerates the process of liver injury. Genetic factor predisposed to not only alcohol liver disease but alcoholism as well. Polymorphisms in the enzymes predispose to alcoholic liver disease. Iron overload hemochromatosis, malnutrition, especially vitamin A and E deficiencies, can worsen the alcohol liver disease by preventing regeneration of hepatocytes. What are the symptoms? Symptoms vary based on how bad the disease is. There may be no symptoms early on. Symptoms tend to be worse after a period of heavy drinking. Digestive symptoms include pain and swelling in the abdomen, decreased appetite and weight loss, nausea, vomiting, fatigue, dry mouth, increased thirst, bleeding from enlarged veins in the walls of the lower part of the esophagus. Skin problems because of jaundice, there could be yellow coloration in the skin, mucous membrane or conjunctiva, small red spider-like veins on the skin, very dark or pale skin, redness on the feet or hands, and could be itching. Now, the brain and nervous system symptoms include problems with thinking, memory, mood, fainting and lightheadedness, and numbness in the legs and feet. How do we diagnose? History and examination. Detailed history of alcohol use is very important. So, one thing is there that we have to take the patient into confidence. And symptoms like nausea, vomiting, jaundice, and abdominal pain, lab tests, blood tests are done to assess the liver function. AST by ALT, that is the D-Ritis ratio, is often more than 2:1 in alcohol liver disease, unlike in other liver diseases. There's increased serum bilirubin, decreased albumin, prolonged prothrombin time, and INR. CBC for anemia and low platelet count is done. Gamma glutamyl transferase is often elevated in ALD. Carbohydrate deficient transferrin is done for heavy alcohol intake. Phosphatidylethanol to detect the recent alcohol intake. Imaging tests and ultrasound scan. CT scan only if very much needed. Otherwise, we prefer to avoid CT scan. It's not considered very safe in pregnancy. Or MRI scan can be carried out. These scans produce detailed images of the liver. Imaging studies do not confirm the presence of alcoholic liver disease, can be used to assess for hepatic parenchymal changes. Ultrasound, MRI can be used to diagnose fatty change, cirrhosis, or neoplastic disease of the liver. Sometimes you may need to do a liver biopsy. In this, under anesthesia, a fine needle is inserted into the liver and then we take the tissue for biopsy. Biopsy may be indicated in any patient with serum aminotransferase elevations that persist for more than 6 months, even if the patient is asymptomatic. Patients who have evidence of liver failure, example, abnormal prothrombin time or hypoalbuminemia in addition to elevated aminotransferases. If there is coagulopathy, please do not do a percutaneous biopsy, better to do a transjugular biopsy. Patients in whom the diagnosis of alcoholic hepatitis is uncertain based upon clinical and lab findings. But nowadays, liver elastography, that is fibroscan, has replaced the need for liver biopsies, in many cases providing non-invasive ways to assess liver stiffness and detect fibrosis and fat. These newer tests are safer, faster, and often just as accurate and allow us to better monitor liver disease without the risk and discomfort of an invasive procedure. Now, how do we know the illness severity and risk of the patient's outcome in alcoholic hepatitis? There is the Madre discriminate function based on the prothrombin time and bilirubin, and greater than 32 indicates severe disease. 30-day mortality approximately 50%. And model for end-stage liver disease score, Glasgow alcoholic hepatitis score, asymmetric dimethyl arginine score are done to assess the severity of the illness. Now, what are the risks to the pregnancy? Fetal alcohol spectrum disorders, miscarriage and stillbirth, premature delivery. Alcohol use in pregnancy increases the risk of multiple adverse maternal and fetal outcomes. Maternal outcomes, increased risk of GDM, preterm birth, hemorrhage, increased incidence of LSCS. Heavy alcohol use, that is more than 4 to 5 drinks per week, has been associated with early pregnancy loss and stillbirth. A large cohort study by Shaheen and Myers in 2010 reported highest rates of obstetrical complications in women with alcoholic liver disease. Delivery by LSCS, preterm labor, PROM, placental abruption previa. In pregnant patients with prior liver disease, even the decompensated patients were more likely to develop ALD than the compensated patients. But there is no clear data whether pregnancy actually affects the natural progression of alcoholic liver disease. There is now, what about the fetal outcomes? So, there is no safe amount of alcohol that can be consumed in pregnancy without harming the fetus. Increased risk of FGR, low birth weight, small for gestational age, poor APGAR score at birth, preterm birth, cognitive, behavioral, and social deficits, that is the FAS, fetal alcohol syndrome. These children may have clinical manifestations from mild development delay to severe intellectual disability. Now, this is a picture showing a child with fetal alcohol spectrum syndrome. So, this is the small head, low nasal bridge, epicanthal folds, short nose, thin upper lip, underdeveloped jaw, flat midface, short eyelid opening. So on the left side, you see a normal brain of a baby 6 weeks old, and on the right side, brain of baby same age with fetal alcohol syndrome. So you can see how much effect it has on the various organs of the fetus. We've discussed this. So the actually effects of alcohol start right from in utero, and in all the stages of fetal development, there is some effect to some organ of the fetus. Managing ALD in pregnancy. Alcohol abstinence. Abstinence is the most important therapeutic intervention for patients with alcohol liver disease. Abstinence has been shown to improve the outcome and histological features of hepatic injury, as I said earlier, but in those not in cirrhotic liver, to reduce portal pressure and decrease progression to cirrhosis, and to improve survival at all stages in patients with alcohol liver disorder. Less than 20% of patients demonstrate progression of liver disease after abstinence. 5-year survival improves from 34% to 60% for those with decompensated liver disease. Non-nutritional diet. Alcoholism is associated with nutritional deficiencies. The presence of significant protein calorie malnutrition is a common finding in alcoholics, as are deficiencies in a number of vitamins and trace minerals, including vitamins A, D, thiamine, folate, pyridoxine, and zinc. Nutritional supplement improves hepatic function. Patients consuming more than 3,000 kilocalories per day, there is virtually no mortality, and those consuming less than 1,000 had in 80% cases 6-month mortality. Drug therapy. Alcoholic hepatitis, prednisolone is the drug of choice. 40 milligrams orally daily for 4 weeks and then taper the dose. Folic acid deficiency, 1 milligrams orally daily in conjunction with improved dietary therapy causes until the repletion occurs. Thiamine deficiency, 100 milligrams orally or subcutaneously daily for 2 weeks or until deficiency is repleted. Vitamin D deficiency, ergocalciferol, 12,000 to 50,000 IU orally daily. Reassess vitamin D serum levels in 2 to 3 months. Vitamin E deficiency, 400 IU orally daily. Vitamin A deficiency, 25,000 to 50,000 IU orally 3 times a week. Silymarin, this is the major constituent of milk thistle extract. Antioxidative and antifibrotic properties are there, believed to enhance liver regeneration and protect hepatocytes from toxicity. Recommended dose is 140 milligrams 2 to 3 times per day. Many reports say that it is not safe in pregnancy, but some studies have shown its safety in pregnancy. So, treatment of acute alcoholic hepatitis with prednisolone with or without N-acetylcysteine. So, prednisolone 40 milligrams per day was given for 28 days plus NAC IV with 5% dextrose on days 1 to 5. And then in the other group, prednisolone 40 milligrams per day for 28 days plus 5% glucose IV on days 1 to 5. And there was a definite better result when we added prednisolone with N-acetylcysteine. 2021 American Association for Study of Liver Disease released new practice guideline that support the use of naltrexone in pregnant women with alcohol liver disorder. Dose is 50 milligrams per day for 1 to 2 months. It is found to be safe in human studies, binds to opioid receptor, so blocks the pleasurable effects of alcohol and reduces the cravings. It is also safe in breastfeeding women. Role of probiotics. Probiotics have a strong role in treating alcohol addiction. The potential of probiotic therapy is demonstrated by the way they modulate important neurotransmitter pathways implicated in alcohol addiction. They decrease the neuroinflammation and restore balance of gut flora. More research is needed, however, to fully investigate the therapeutic potential of probiotics. So, to conclude, it is very important to stress the importance of no intake of alcohol to pregnant ladies. There is no safe amount of alcohol that can be consumed without harming the baby. It is the most important cause of non genetic disorders in the fetus. History taking is very important, so take the patient in confidence. Many drugs otherwise used to treat alcoholic liver disease are not safe in pregnancy, like pentoxifylline and metadoxin. So say no to alcohol for a safe and healthy pregnancy. Thank you so much.
Thank you, Dr. Ranjana Khanna, ma'am. Excellent talk. And I think when we were young, we used to hardly ever see alcoholic liver disease in
Yeah,
pregnancy in India. But now, with the advent of westernization and
yeah,
different addictions, social drinking, different lifestyles, we are the ones experiencing culture shock and seeing more and more of these patients. So, we definitely need to
exactly.
be prepared to tackle these issues when they come in, and we have to tackle them in a sensitive manner because finally we are dealing with two lives, not one. Thank you for an excellent talk, and we'll move ahead to the next.
Excellent
Thank you.
talk, madam. We can see so many hearts and folded hands. Yeah,
Excellent
it's
talk, madam.
really
You
very good
covered
talk.
everything. And we used to neglect the history of alcohol intake during peri-conception period. And that is very, very important. We
Yeah.
should
Because nowadays it's become a sort of a fashion to drink. So if you're not taking alcohol, you are like LS. And if you're taking alcohol, you are the in person. So because of that, I think that is why Kanchan chose this topic actually.
Yes, yes, madam. Thank you. It was really a wonderful talk. And I think Dr. Manjul has not joined yet. Manjul Pandya.
Sir is
Has he
joined,
joined?
ma'am. Sir
He
is
has
joined.
joined?
Yes.
Acha,
Yes,
okay. Okay,
I'm
that's
here.
good.
Okay. Hello.
Okay, welcome,
Good
welcome.
evening, ma'am. Yeah.
Okay, good evening, sir.
Good
And
evening, ma'am.
thank you, Ranjana ma'am, for such a wonderful and practical talk relevant for everyone. I request Dr. Brijbala Tiwari ma'am, to kindly introduce Dr. Manjul Pandya.
Yeah, thank you. It's my privilege to
Manju.
introduce Dr. Manjal. And Dr. Manjal is Associate
Manjal.
Professor at Narendra Modi Medical College. And he is FICOG Diploma in Minimally Invasive Surgery. And well-known figure, he is President-elect Ahmedabad OBGY Society for 25-26. Gujarati Book Club President. And I received one beautiful book by, I think so many people of us have received that book by Dr. Manjal, and he is winner of Dr. Kamini Rao West Zone Yuva FOGSI Oration 2021 and co-edited books
Thank
on
you,
male
ma'am. Thank you. Thank you.
infertility. So
Yes.
many credits to your credential. Dr. Manjal, over to
Thank,
you for your talk.
thank you so much, ma'am. Thank you so much, Brisbala ma'am, for your kind words of introduction. Thank you so much, Kanchan ma'am, as well, for the opportunity and ICOG. And I'm really, glad to have this topics being covered by Kanchan ma'am and ICOG. Because with regards to alcohol, what ma'am said, we just discussed it. We just performed a CS in my emergency, and we were discussing these things. That nowadays it goes or works in reverse. If you do not consume alcohol, if you do not do the so-called high profile parties, the matrimonial proposals are being rejected. So a boy from Jain family came and we discussed a lot. And then he said that I am actually searching for an appropriate prospect. And one of the girls rejected me because I did not drink alcohol. So I think nowadays it's very, very essential to cover these topics. And I'll try to cover up something with regards to tobacco and fertility. Obviously, Obviously, we know a lot about it. It will be just brushing upon the knowledge that we already have. I'll just start my screen sharing. Just a second. I hope my screen is visible.
Yes, sir.
Yeah, thank you. Thank you so much, ma'am. So with regards to tobacco and fertility, I have tried to cover up a few salient points with regards to the female part as well as the male counterpart. When it comes to tobacco, we know the culprit is most of the times, I mean, the major culprit is nicotine. In next few slides, in next 15 minutes to be sharp, we'll be covering something with relation to the epidemiology, global as well as the national scenario, pathophysiological changes which contribute to the gamete or placental damage, which is the oxidative stress, all the toxicants, endocrine disruption, and epigenetics, the female and male reproductive consequences arising out of it, including the results that would be affected with regards to ART outcomes and transgenerational effects. We already know the Markos hypothesis. Now we have a few of the scientific evidences with regards to the impact on male and female child of a mother who smokes or who consumes tobacco on routine basis. Apply practical counseling, screening, and treatment strategies for smokers seeking conception or the advice regarding conception. Globally, ASRM has data with regards to 2008 year and 2024 as well. In both the studies or both the papers, they mentioned that the global scenario or prevalence is around 30% with regards to both the genders. And when it comes to India, as we can see in the graph, in the age group of 15 to 19, at least 6.5% males are smokers or do have habit of smoking. If you look at this particular age group, there is one book called Outlive by Peter Attia. He is an oncosurgeon in US, and he mentioned about medicine 3.0. He suggested that the autopsies of homicidal deaths concluded that at least 50% of male or female of age group of 20 to 25 had plaque on coronary arteries. So what he tried to convey was the plaque development starts at 1550, not at 5050. So one of the scientific indicators is right in front of us. If 6.5% of males in this age group before 19 years starts smoking, think about the damage that they are accumulating. Even 1% of female is a huge number because these are the scenario or the surveys which may not be reflective of what happens in the society. Age group 20 to 34, and it keeps on rising. In India, fortunately, the female smokers or the incidence in females is quite less. But again, with regards to cumulative incidence, it is at least 30 to 35%, which is a huge chunk. And when it comes to the fertility part, on both the sides, on both the genders, it has the detrimental impact. So, which are the products which lead to this particular tobacco consumption? So they are like cigarettes. We know that BD is the cheaper option in the lower socioeconomic class. Smokeless tobacco is just a trend, but it still is a tobacco. E-cigarettes, or we call it as ENDS, they are called as electronic nicotine delivery systems. Now they are on rise as well. We have hookah culture at times in many of the metro cities. Marijuana is something which is now quite commonly used, at least on global fronts, wherever it is available. We were taught in MBBS that passive exposure to the smoke is, I think, something which increases the risk of smoke twice as compared to the active smoker. May or may not be true, but it has a huge impact. So now, fortunately, we have the smoking zones so that majority of the population does not get affected with regards to the smoking, which is done by other person. So passive exposure or second-hand exposure is very, very significantly impacting the fertility as well. And measurable nicotine are found in follicular fluid of passively exposed females, which is a huge impact. And that's why the rise in ART is also there. I think we all are experiencing rise in infertility. Nowadays, they are coming up with the studies that the serum testosterone level is falling in males as well. So a huge impact is there on the future generations with regards to the pollutants and the addiction part they have. So oxidative stress and ROS, we know that is reactive oxygen species. They are the major culprit with regards to many of the disease origin. They lead to DNA damage, lipid peroxidation in gametes and follicular fluid, which is very, very important with regards to the growth of gamete in that particular follicle. Direct chemical toxicants, we have a lot of them: cadmium, nicotine, carbon monoxide. They lead to toxicity in ovary as well as testes, and follicular cadmium accumulation will be there, having larger impact. As we know that the primordial follicles will be numerous, which will lead to the primary follicle or the major follicle or dominant follicle in the next cycle from the cohort of many hundreds of follicles. All of them are getting affected because there will be accumulation of those toxins in that particular ovarian tissue. There will be endocrine disruption leading to altered steroidogenesis, higher basal FHS. Now, why higher basal FHS is a problem? Because there will be a kind of pre-menopausal picture creation in the ovary. And that's why the menopause will come earlier in those females who are regular smokers. They will be having reduced luteal estradiol, again, a marker which is very, very essential for the preservation of fertility. And changes in testosterone and inhibin will be there in men as well. So a lot of things are contributing with regards to lesser gametogenesis or even gametogenesis of lower quality of gametes. Genetic and epigenetic damage, they will lead to DNA adducts and all the malformations with regards to DNA and other chromosomal non-distinction altered sperm methylation patterns, again leading to defective spermatogenesis as well as defective quality of the sperm and sperm motility. And that's where the problem lies with regards to even congenital malformations of the newborn as well. With regards to female fertility specifically, time to pregnancy and infertility, they say that smoking is associated with delayed time to conception. There will be a huge delay, and that's why they would majorly resort to ART protocols or the steps. There will be increased infertility risk. Larger population study found that smokers had 54% higher risk of conception delay for more than 12 months. In a majority of the world, they say that at least 12 months of attempt with unprotected intercourse will be stamped as infertility. But in few of the segments, in US, they used to consider 24 months. But all of them concluded that a smoker or female smoker would have 54% higher risk of infertility, and effect will be present for either partner or for passive exposure as well. So even if the male is smoking, female will be getting affected because of the passive smoking. What would happen to the ovarian reserve and menopause timing? As already discussed, there will be higher basal FSH level, which will lead to earlier menopause, at least 1 to 4 years earlier versus non-smokers, and it will be dose dependent. AMH and FSH, I think 15 years back, AMH was the only conclusive factor, but now we have follicle count and all other factors, and everything combined will reflect the fertility status of the female. So AMH will be quite low. So the response to ovulation induction will be quite less, and FSH will be higher, again reflecting the poor ovarian reserve or poor quality of gametogenesis. Studies show that AMH around 44% lower in some cohorts, and faster AMH decline will be there, at least 21% faster as compared to the non-smokers per year. The mechanism is simple: follicular toxin accumulation, which we have already discussed and studied, along with increased intrafollicular oxidative stress, which leads to ROS generation. They both will lead to plausible cause of accelerated follicular depletion. And that's why the premature ovarian failure kind of picture will be created if the patient is chronic smoker. What happens to the reproductive tract and early pregnancy risk? They said that there are more chances of spontaneous miscarriage. Many of the studies and meta-analysis suggested there will be increased risk of spontaneous miscarriage. Ectopic pregnancy chances will be increased as well. They say that smoking more than 20 cigarettes per day increased the odds ratio to at least 3.5, which is quite high in one case control study. Prospective cohorts show smaller but significant increases as well. The mechanism is very simple. Impaired tubal ciliary function will be there because of nicotine impact. And oocyte pickup demonstrated in animal that there are more chances of ectopic pregnancy because of chronic cigarette smoking. What happens to assisted reproduction or IUI or IVF or other IVF techniques? They say that smoking reduces ART success. The meta-analysis suggested that lower conception and live birth rates were there in chronic smokers. And that's why the ART cycles or required ART cycles will be more, reaching up to conception, and that's why the economical and psychological burden will be quite high in those smokers. Smokers often require higher gonadotropin dose because they have low AMH. They will be having lower peak estradiol level, which is again a marker being used for IVF cycles, and fewer oocytes retrieval, and that's why the ovum pickup again will be having low quality of ova which are retrieved. Higher cancellation rates because the embryo may or may not be developed out of that defective ova, and thinner implantation success will be there. And that's why I think the donation of ova will be higher in these patients as well. The passive smokers would be associated with poorer ART outcomes compared to non-smokers as well. They had detectable follicular cortinin levels correlating with worse cycle metrics. So ART cycles and their failures will be higher on chronic smokers. What happens to the semen? They say that everything with regards to semen will be abnormal in chronic smokers in male. They say that sperm concentration, motility, and morphology, everything will be altered. There will be reduced density, that is 10 to 22% reduction as compared to the non-smokers. There will be reduced motility. So nature or dependence on the nature and spontaneous intercourse will be having failure or higher failure rate because motility will be affected as well. And they said that 13% reduction in sperm density will be there as well. So even if you go ahead with IUI, there will be defective ova majority of the times. There will be defective sperm. So even success rate with IUI will be quite low. And that's why the recourse to the ART will be high. The results are heterogeneous. Some large studies find that minimal differences after confounding adjustment, but then again, sperm will be affected. So male infertility will be there in male chronic smokers. What happens to the gamete and DNA damage? They said that DNA adducts and oxidative base damage are increased in sperms of chronic smokers, male smokers. Chromosomal abnormalities will be there. They call it as Y disomy. That means increased sperm disomy will be there, along with meiotic spindle disruption. So genetically defective will be there in female oocytes as well. Epigenetic changes, they said that global methylation changes and altered sperm methylation patterns are reported in male smokers, and they are pathway for transgenerational effects affecting even the offsprings of male and female smokers. What happens to the reproductive endocrinology in male? In a male, the smoking will be affecting or altering the HPG, hypothalamic pituitary gonadal axis, that is FSH, LH, and testosterone. The results are still inconsistent, but majority of them showed fall in gonadotropins, and that's why the male fertility will be reduced. There will be erectile dysfunction. We nowadays see a lot of patients, if we explore the history of infertility properly, whom we refer to the urosurgeons for further management. But smoking is an established vascular risk factor for erectile dysfunction. And mechanistic plausibility. Okay, mechanistic plausibility via endothelial dysfunction, reduced penile blood flow, and hypoxia will be there. We must not forget that smoking may be a resort for the patients or the male or female as something which is stress buster. And when it comes to infertility, it adds on that particular stress. So it is, I think, a vicious cycle. The psychological aspect is still being missed. And that's why the smoking and all the stress of the couple should be entertained well before putting them on the ART cycles. And erectile dysfunction always I think comes up with regards to the performance pressure as well. So a lot of psychological aspect needs to be entertained for this couple as well. What happens to transgenerational impact? They say that maternal smoking in pregnancy is associated with reduced sperm count in adult sons. So those females who had smoking habit had sons who had problems with semen and sperm. Evidence also supports that parenteral preconception smoking can alter offspring outcomes via genetic DNA damage and epigenetic transmission. So both the things are proven in animal as well as human studies. And that's why everything is falling in line with the Markov's hypothesis. What happens to pregnancy? I'll just brushing it upon in brief. There will be a lot of problems with regards to fetal growth, miscarriage. We already studied ectopic pregnancy chances will be there. There will be preterm birth, placental abnormality with regards to placenta previa, and perinatal morbidity as well as mortality will be high. We know the simple mechanism. Even if the pregnancy goes beyond 6 or 7 months, the nicotine will be having systemic vasoconstriction leading to reduced uteroplacental blood flow, and that's why there will be intrauterine growth restriction. And there might be perinatal mortality as well. So smoking is something which needs to be stopped for both of them. What happens to birth effects? As we discussed, the quality of ovum and quality of sperm both will be damaged because of a lot of DNA damages happening in the gametes because of smoking, and that's why there are more chances of birth effects. As they said, spontaneous abortion will be high, and congenital malformations will be there, but then still further studies are required with regards to confirmation of that. Now, what are ENDS? They call it as vaping, which is again not allowed in flight. We do keep on hearing this particular word in flight instructions. So it is like electronic nicotine delivery system. Uh, the evidence is limited with regards to its impact on fertility, but emerging studies show that lower sperm counts will be there in those users or male users who have this ENDS. And concerning pregnancy outcome signals, that is higher low birth weight were noted with regards to female users. Smokeless tobacco again is a gimmick, maybe. It is associated with increased pregnancy loss and adverse outcomes, and suggests that nicotine or constituents beyond combustion products are harmful. So, in a way, I think it is more of stress and their own gateway to remove that stress, which are harmful, and that's why again the psychological impact needs to be entertained. What are the biomarkers? We already studied that AMH will be low, FSH will be high, and that is basal FSH. We usually go for this markers in at least second or third day of menses, which would reflect a lot with regards to antral follicle count. And that's why this is very, very important investigation with regards to the probability of success of ART cycles. Cotinine will be high in urine, serum, as well as follicular fluid, which will again have worse ART outcomes. Semen DNA fragmentation is very important with regards to semen analysis, and other products will be explained with regards to male smokers, and they show that oxidative damage will be there along with the nuclear damage, and they might contribute to unexplained male factor infertility. Counseling and cessation, as we discussed, it is very, very important. When I was in second MBBS, I tried to, counsel a smoker that please stop cigarette, it is harmful, and etc. I never did know that it has to have a gradual withdrawal, and that's why I think it is very, very important to know. We cannot just simply say and they will withdraw. They have to have proper gradual withdrawal from that particular addiction, which might be having some kind of mood elevation in their own minds, and that's why it is very, very important to include psychologists or proper counseling, professional counseling with regards to cessation. And a lot of things are now available. Gadgets are available to have a normal, healthy lifestyle restored. The mobiles are full of such applications, and we can make a great use of them as well. Partner engagement is very important. I think it's not a responsibility of male or female. It's not about defect in male or female. It's about having proper aligned goal and then proper aligned efforts or attempts to have that particular goal or combined or one particular goal. And that's where the real definition of couple sets in. So practical guidelines, preconception visit is must with regards to those patients who are vulnerable for tobacco usage. And if there is smoking with infertility, urgent cessation counseling is required with regards to all the explanation and all further steps with regards to increasing the chances of ART outcomes. Pregnancy, prioritize cessation stoppage, make them think that it is a life growing within them, and feel them responsible with appropriate medical steps. Research gaps, we need for a
Sorry to
lot more
interrupt
research.
you, sir. Your time is up.
Okay, a lot of research is required with regards to the newer gadgets, and I'm really sure that with regards to the bulk and all increasing usage, we'll be able to have a proper outcome. So key takeaways, smoking is harmful, smoking is injurious to health, and still we see a lot of advertisements on cinemas and everywhere else. Why shouldn't we stop those advertisements in the first place rather than having that a little caption on the side? So let's be a responsible citizen, a responsible doctor, and let's keep on trying to have a healthier society so that there will be less disease and more health. Thank you so much. I hope that I did justice to the topic given to me. Again, thank you so much, Kanchan ma'am, for believing in me, and I'm really thankful for the opportunity. Thank you.
Thank you, Dr. Munjal. It
Thank
was
you.
excellent
Thank
talk.
you. This was
It's
excellent talk,
affecting
really.
not only fertility, but long-term complication in offsprings as well due to epigenetic changes, and not only direct smoking, but the passive smoking is also need to be, so that is also very important. Thank you so much.
Thank you, ma'am. Thank you so much, ma'am.
Dr. Rajshri can take, na?
Suchitra Pandit ma'am, I can take.
Okay.
Okay.
Dr.
Dr. Kanchan,
Rajshri.
permission to speak?
Madam is there, na? Okay, I don't know.
Suchitra
I'm
ma'am is
there.
there.
I don't
Yes,
know I'm
yes,
there.
ma'am is there.
Since last 1 hour I'm there.
I will be the last one, so I'll
I
get
have heard
before.
everybody. I've since
Ma'am,
last 1 year I'm tuned in.
then आप
Okay,
लीजिए.
madam, welcome, welcome. We especially
Welcome, ma'am.
welcome you. And our MOC, Dr. Seema
Yes.
Dwivedi.
Namaskar,
Please,
ma'am. Welcome, ma'am. Going ahead in the webinar with session 3 of Lifestyle, Public Health and Preventive Strategies. We have as chairperson in this session Dr. Ashok Kumar and Dr. Sheila Mane. Introducing our chairpersons, Dr. Ashok Kumar. He is Director, Professor and Head Department of Obs and Gynae, Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital, New Delhi. Vice Chairperson, ICOG 2025, with more than 100 research papers and conducting many ICMR projects. We welcome you, sir, as our chairperson. Our second
there?
chairperson, hello.
He is
Our
there?
second, ma'am, I tried to trace him, but I could not see his name. But since he has been invited, we would love to introduce him. And our second chairperson, Professor Sheila Mane, President-elect ICOG. She is a magnanimous personality with vibrance of sun and tranquility of moon. Has been Vice President FOGSI 2014, Chairperson Safe Motherhood Committee, President BSOG BMS ISOPAP Bangalore Chapter, National Facilitator of Adolescent Health in BHU, Reviewer for Jogi, and she has received innumerable awards for her contributory work. Welcome, ma'am. Going ahead with the session, I request our chairpersons to kindly introduce our speakers. Our first speaker for the topic of diet, lifestyle and non-communicable diseases.
Excuse me, Dr. Sheila
हाँ,
Mane muted हैं वो उनको on करिए the technical team because she had a message to me.
Yeah, and some this black thing is coming on the screen also.
Can I
Dr.
share?
Sheila Mane को Shreya
Yes, ma'am.
मैम
she's
आप
a
शेयर कर
chairperson
दीजिए.
and is
I've
muted.
sent her a request.
हाँ आ गए ना मैम शीला मैम.
Sheila
She's
ma'am,
there, but she's muted.
Can I share the slides?
Yes,
Okay,
I would
thank
like to
you.
request our
Yeah.
chairperson.
It is done,
I
done. Okay.
I'll,
Can I have
I would
Dr.
like.
Suchitra CV, please? Yeah.
Yes, ma'am. Welcome, ma'am. Welcome,
Yeah,
Sheila
thank
Mane,
you,
ma'am.
Dr. Seema. Yeah. So I thank Dr. Kanchan for inviting me and making such a wonderful masterclass for ICOG. So on behalf of ICOG also, I would like to thank you. And we have none other than our beloved Dr. Suchitra Pandit, who is going to talk about lifestyle modification. I think after listening to all these things about all the NCDs, and this plays a very important role, whatever treatment you are offering or whatever you are doing. And everybody really needs to follow that because that should be the way forward for everybody. And Dr. Suchitra Pandit, our past president and past secretary of ICOG, past president of ISOPAP, as well as she started the HDP guidelines during her presidential year, as well as we know that how actively she has conducted all the adolescent health programs in Dharavi, in Mumbai, and many more accolades. And she has presented many papers nationally, internationally, and also a a FOGSI representative to FIGO. And I had a privilege of being her vice president, and I was able to do so much of my work on postpartum hemorrhage. So over to you, Dr. Suchitra.
And
Be
she is the
welcome.
co-chair of CEFOG NCD committee. So, madam, welcome.
Can I share my slides first, please? Can I just do that? Yeah, just a second. Are they seen?
Yes.
Not yet.
Yes, yes. Yes.
Just a second.
Now we can.
Okay, all right.
Full screen.
Thank you very much, Dr. Sheila and Dr. Ashok Kumar is not there.
But yes, Sheila and me go a long way back. And Sheila, we are looking forward to your year as ICOG chair. And we've done a lot of work together. So let's now focus also on preventing NCDs. And thank you, Kanchan, for this opportunity. I'm going to be speaking on role of diet and lifestyle changes in preventing NCDs. I think everybody knows what NCDs are. But WHO in 2018, and now they've revised and got on further figures where they are saying that they're the leading cause of premature deaths, and about 41 million of the 57 million deaths were because of NCDs. It's a non-infectious disease condition which can last for a long time, doesn't spread, but then it's a silent killer because it can cause chronic symptoms. So people are not really worried, they just carry on. And the disease that are included, we know all of them, but some of the well-known ones are anemia, diabetes, hypertension, obesity, cardiovascular disease, stroke, and cancer. But the lesser known ones are mental health, dementia, chronic respiratory diseases, infertility also, and changes in lifestyle, increasing in the age, the aging population, unplanned urbanization and globalization are very, very, important for this rise. And these diseases can affect both men and women, and they can affect all income groups. So the major factors are unhealthy diets. We'll talk about that just a little later. Physical inactivity, and a good start, therefore, should be to incorporate more physical activity in our daily routine, and tobacco and alcohol misuse. So now let's see what are the lifestyle changes and what impact do they really have. So for CVDs, that is the cardiovascular diseases, adopting a healthy lifestyle can significantly reduce the risk of CVD. Apart from a healthy diet, it's also engaging in regular physical activity, avoiding smoking in any form, and Munjal has really nicely talked about it. Excessive alcohol consumptions are the key lifestyle changes that can prevent the disease. Type 2 diabetes. People say, oh, it's in my family, so I got diabetes. But if you have healthy lifestyles along with regular physical activity and a balanced diet, they can actually prevent or delay the onset of type 2, and they can keep it in perfect control. So these changes will not only improve the insulin sensitivity, but they will also risk the diabetes complications. And obesity, they go hand in hand with diabetes, an independent risk factor. But apart from a family history of obesity, healthy eating habits and regular physical activity are central to preventing obesity. And these changes will reduce the risk of various NCDs, including diabetes, stroke, and heart disease. So let's see what are the role of foods which we eat in preventing NCDs. In the olden ages, we all used to sit down on the floor and eat on plantain leaves, and we used to have wonderful balanced diet, and that gave way to the plates and the tables, and now none of us can sit on the floor and eat. But we should know that if there's a healthy dietary pattern, there's a lot of benefit. It keeps a healthy weight, lowers the BP, lowers the risk of all these NCDs, and not just that you start feeling good, but what is important and strongly recommended by WHO is reducing the portion intake and the frequency of the meal. So intermittent fasting, we call it Dixit's diet, but internationally it is called as intermittent fasting, could potentially prevent and delay the onset of NCDs without occurrence of malnutrition. And there are certain specific foods. Now we talk about a Mediterranean diet where there are more of vitamins, more of metals, more of polar lipids. But look at even our old Indian diets. They were so good, they were balanced, they had everything. They had fruits, vegetables, everything coming from the plant kingdom. Those who ate non-veg, they were fine. Those who ate veg, they were fine. But what has changed now is we have changed our patterns of eating, and we have stopped eating fruits. Our children have stopped eating the only fruit and the only vegetable they know is potato and paneer. And that's how, if the generation has changed the eating habits, obviously the incidence of NCDs is going to go very high. And gut microbiota play a very pivotal role. Sheila will remember because she also comes from the same region as I come. We used to have this habit of having buttermilk, or plain tak, as we call it, chas, that has got plenty of microbiota and that used to help in digestion. But up then now everything has changed. People say, oh, is that important? And then you suddenly see Shah Rukh Khan's wife talking about how buttermilk and how kanji would help in digestion. So this is now coming back, but I think we should realize that these were very, very important habits which we had. So eating more fruits and vegetables, aim for at least 5 portions per day to reduce the NCD risk. Choose whole grains, millets. So many forms of millets are there. Pulses, legumes. Limit the unhealthy ingredients like unhealthy fats, processed foods. Reduce the intake of sugar and salt. Even kids from the, when they have born, the mothers have started working, breastfeeding has stopped, they will put 2 spoons of sugar in a cup of milk or in a bottle of milk. So that practice should totally stop. Even lean protein like fish, poultry, eggs, or lean meat is much better. But please start drinking more water because people don't drink water. 1 liter or 1.5 liters in our tropical countries is not advisable. At least 3 liters. Avoid colas. Avoid too much of coffee, that is black caffeine, which they drink 6 to 7 cups a day. And the eating habits which we are talking about should start right at childhood, should apply to adolescents. The incidence of adolescents obesity and thereby NCDs is taking its roots right at a very young age. So I'm not going to go into details of this, but just to tell you that when you're talking about BMI, the overweight and the obese should have a multi-pronged intervention that has been dealt with. But friends, let's not just talk about pharmacotherapy and nutraceuticals. Let's talk about nutritional modification, mental mindset. That's where the counseling is important, aerobic and strength conditioning, because that's how we are going to change. And that's where, again, the lifestyle. Now, again, lifestyle for changing dietary habits requires a lot of behavioral strategies, promote a healthy eating habits, awareness campaigns, taxing unhealthy foods, making those taxes very high, restricting the marketing of unhealthy foods and sugary drinks. And this should start at schools and workplaces. Increasing physical activity, very important. So in Sweden, I know everybody cycles. They hardly use vehicles excepting in the very, the snow time, winter time. Otherwise, they're doing cycling everywhere. Netherlands encourages a lot of cycling, and we should also encourage our children. We have to create safe spaces for them to play, and there should be physical activities in schools, in colleges, in conferences, and there should be role of behavioral therapy and stress management. The reason I said conferences, sometimes we are sitting for 3 and 4 hours, so we should get up, walk, move around, maybe lift up our hands down, do some activity. So this behavioral therapy again is very, very important, particularly starts from school, but it is a basic skill to adhere to a healthy diet, increase physical activity, manage stress effectively, quit smoking, and reduce alcohol consumption. And Dr. Sunita Tandurkar, our president, she was just telling me, just learn to, completely, you know, put a Fevicol on your lips and don't eat anything beyond what you have to eat. So, which is so true. And all of us, love food, but we have to know how to eat. So if you're wanting to go on a crash diet, please don't. Seek professional help for weight loss. Timely eating include all these wonderful things which I've shown in the picture. Regular follow-up for counseling if you're treating a patient wanting to lose weight, and creating awareness, because it's not about zero figure, it's about feeling good from inside. And friends, we are gynecologists, start talking about preconception counseling about weight reduction right before they come to us when they're already obese. So WHO has recommended physical activity, which is a key lifestyle in preventing NCDs, and this is a part of a lifestyle change. The AHA says 150 minutes per week of moderate intensity aerobic activity, or 75 minutes per week, which is not too bad, of vigorous aerobic activity, or a combination of both, preferably spread throughout the week. And here I want to say that sometimes, when you're doing it alone, there is lack of motivation. So joining a group of friends, and I've seen Sheila following the yoga on the 6 o'clock in the morning on the phone. I've seen so many people doing that. So if you want that motivation, I think that's where it really helps. So that regular physical activity is fantastic. Whenever I exercise regularly, I feel so positive throughout the day. So regular exercise not only gives a positive impact on the health, but also reduces all the NCDs, and most important, friends, anxiety and depression. So be physically active, avoid tobacco, limit alcohol and substance use, prioritize sleep. I'm going to talk a little about sleep, manage stress, and look at your dental hygiene because that is very important to determine your eating habits and have a regular dental visit. The sleep hygiene is very, very important for maintaining reduction of NCDs. Consistent schedule of going to bed and wake up. I know as gynects we can't have that all the time, but we must have a relaxing bedtime routine with calming activities like reading, taking a warm bath, listening to music. Limit naps to 20 to 30 minutes and avoid it late in the afternoon. Use the bedroom for sleep and privacy. Many people have TVs in their rooms. Avoid that. And don't take your laptops to the bed and say, I'll fall off to sleep, because the laptop gets left and you halfway sleep through and you're getting disturbed by all those little noises that keep coming. So even with your phone, just stop those alerts, or you can even have earplugs at night. Ensure a comfortable mattress and pillows, and no coffee before going to bed, no alcohol. Don't have a large meal. Our conferences, our executive class, our young people, residents all eat at 11 o'clock, 12 o'clock in the night. There is no exercise. They go off to bed. And please, friends, that is something which we must teach us ourselves and our younger people also. Limit the screen time. Many of us have got that bad habit. Let me just check through the WhatsApp, and then you go on, and the YouTube, and you just go on and on. Just stop that. The blue light can disrupt the melatonin production. Turn off your notification, and if you get up in the middle of the night, don't look at the clock, because then it adds on to the anxiety. Snoring, though it is not typically an NCD, but it is an important risk factor for developing NCD, particularly high BP, heart disease, stroke, and type 2. And friends, after the age of 50, many of us also snore. But if the snoring is very loud and it is causing a problem, your sleep is getting disturbed, and there is a sleep apnea, please speak to the sleep experts and get that CPAP machine. It's very easy to carry. Loud snoring is a sound of air struggling, and this is gasping for air. So it's very scary for somebody who's in the house to hear that. But please, friends, look at that. All snorers may not have sleep apnea, but those who have got loud, disruptive, gasping, snoring sounds, they will have less of sleep and they will feel tired, and tired they have difficulty in concentrating, and slowly the BP goes up. And morning headaches, I've heard of many doctors also talking about morning headaches. Watch out for the high blood pressures. So change lifestyles, have that CPAP machine. There are special mouthpieces that repositions the jaw to keep the airway open, and in very rare cases you require a surgery. Just two more slides. Preventive measures reducing air pollution. Friends, today where I'm staying in Santa Cruz, there are 6 buildings up for construction. So I have to close my windows at night because there is so much of dust coming in the day and the night. But let us start using masks wherever we feel it is required. And if there is a breathing problem, please consult your respiratory physician. NCDs, yes, we obstetricians can reduce it. So though we know that NCDs are a big, big chunk for men and women, we as gynecologists can play a superb role by prioritizing integration of MNCH care, and Rajesh is going to talk about it. But major modified risk factors can be picked up, and we can address these barriers, have the community-based approaches. Let us all do it, even culturally, let us put that into it. And last slide, public health initiatives, very important for reducing pollution, promote smoke-free zones. Even Modi ji has helped in reducing the pollution for the cooking also. And of course, I feel scared to even talk about the war areas, the Gaza area, poor little girls and women having all that problem. But even in the house, completely ban smoking. So lifestyle plays a very critical role. Healthier choices for our food and daily activities. Prevention is better than cure. And Rajeshri, you can help us to go up to the level. Sheila can help us, integrate maternal, child, and newborn care with screening for NCDs. And ask yourself today, instead of having dessert, will you have a piece of fruit? Thank you very much. Every small change makes a step closer to healthier life. Thank you very much. Thanks, Sheila, and thanks, Kanchan, for a
Thank you,
patient hearing.
madam. This was
Thank you.
really a wonderful talk.
Thank you,
Sorry, Parag
Suchitra.
is also there. Let me just say hello to Parag, chairperson of ICOG, and my dear friend. Hi, Parag.
So thank you, Suchitra. I think in a nutshell, prevention, how important it is, that is very, very important. So recently I have been reading about the FIGO pregnancy passport. And I think those who are listening to this, you can access it through FIGO website. And it's very important. It is particularly for the patients, those who have morbidities during pregnancy. And it is a simple document, and we should start doing it. In fact, I want to start, Suchitra, in ICOG. I will talk to you later, and we have to see that we can really collect so much of data. We are talking about NCD prevention. So it starts, patient has HDP, she has GDM, she has some cardiac problem. We can follow them up so that, they are aware. We know about GDM now, we know. And we know very well that if the patient has developed hypertension, the next 10 years she has a chance of developing IHD. And now IHD is on the rise. So we should start this FIGO pregnancy passport, which is nothing but a documentation. We ask the patient to come for regular follow-up. So far, we did not have any such measure. So requesting all that we take it forward. We'll take it forward through ICOG also. And Kanchan, you can continue to work for this. Even though I think, even though you are going to finish your I think this will be the very good initiative for the prevention. Okay. And thank you, Suchitra. I always, your talk is very motivational for everybody. So thank you.
Thank you, madam. Thank you.
Thank you, Suchitra ma'am, for a wonderful talk. Going ahead with the session, I request Sheila ma'am to kindly introduce our next speaker, Dr. Rajeshri Katke, who is going to give her talk on government schemes. How can we participate? Hello.
Yes, ma'am.
Sheila ma'am, if you kindly introduce our speaker.
Yeah. And she's a very senior obstetrician and gynecologist, and she's more than 2 decades now. She's an undergraduate and postgraduate teacher, researcher, editorial and author, and associate member of RCOG. She has more than 100 publications, national and international, and 394 plus citations and 211,000 global reads. We have an academician with us. She has many awards to her credit, and she was appreciated by General Secretary of United Nations Honorary Ban Ki-moon work in women's health, and awarded by Honorary Chief Minister, that is Bid Mahanagarpalika, and many more awards to her credit. So I welcome you, Dr. Rajeshri. I think it's very important because most of the time we are in private practice and we don't know the government initiatives. So it is good to learn about that. Thank you.
Yes.
Welcome.
Thank you so much, ma'am. I'll just share my this thing. One minute. This what is happening? This has not.
On your window, this is opened or not?
Yeah. Window is open, but
Yes,
why
first
it is
press the
not?
share.
Share.
Rajeshri, close this window.
Yeah, I'll close this window.
And have you got it on your desktop? Then you'll be able
Yeah.
to.
I have kept it on desktop actually. So why?
Minimize this, and you will see.
Yeah. 1 minute. Okay.
On your desktop, you have not opened that slide.
You have to share the PowerPoint window, not the browser window.
Yes.
Now
it is visible?
Yes.
Full screen.
Yeah.
Just make it full screen.
Okay. I'll make it. Yes. Okay.
Ma'am, slideshow. Go to slideshow mode, ma'am.
Yeah, I have gone. This is new instrument. So this.
मैम जहाँ पे होम इंसर्ट ड्रॉ लिखा है ना उसके आगे
नहीं
एनिमेशन
वो
के
है,
आगे
लेकिन वो क्या है मेरा वो जरा
आप नीचे भी आ सकते हो, सबसे
नहीं
नीचे.
नहीं I will do that. Play from start. Okay.
Yes, ma'am.
Done. Correct.
Yes, ma'am.
So let's talk about the NCDs. The incidence has already been covered. Basically, it is being killed 41 billion people each year, and it is very important to go for that. The non-communicable diseases are the cardiovascular, cancer, and the chronic respiratory diseases, and the diabetes one. So to grassroots, if you can say that about the tobacco, unhealthy lifestyles and the diet, this already being covered in that. I would like to go quick to the this thing. So what is the burden of the NCDs in India? So basically we have 54.5 million, then IHD, COPD, asthma and the diabetes. And the mortality due to NCDs are in India is more with the chronic respiratory diseases and CVD. That is very important to have. This I think madam has covered in this. But what we are worried is that this NCD deaths and 86% of the 17 million people died prematurely. Here is the one important thing where the government plays a role in that. So basically, this is even with the pregnant patients also, we are having most of the mortality with the NCDs, but prevention has given into improve into the mortality rates in that. This factor has been covered in that. Maternal age, behavioral risk factors, then urbanization. What are the transition which has a 5 stages? One is that we have a few resources, lack of access of the facility care, challenges of accessing care, and a lack of quality care. And the NCD is the main cause for the having more of the complications, which is going into the mortality, which is from the infectious to the non-infectious. So health system has to be re-engineering, and for that the government role is very important in this. So WHO target is that around 3.4, SDG around 2030 with the mental health. This is our target in that. This MMR should be 70 days per one live birth, and SDG for the non-communicable diseases, it should be 3.4 calls to reduce by 1/3 premature mortality. So what are the objectives? How we should look in the government is that one is the health promotion, second is the opportunistic screening, and prevention and control of the chronic non-communicable diseases. To build up the capacity is very important, the public and the private sector, which helps into the prevention, early diagnosis and the treatment. To support for the diagnosis, you should have a primary, secondary and the tertiary levels for the healthcare. To support for the NCDs through the surveillance is very important to reduce or monitor the NCD morbidity and the mortality. So what are the strategies? Health promotion, awareness and promotion of the healthy lifestyle, screening and early detection, timely, affordable and accurate diagnosis, access to affordable treatment and the rehabilitation. This is the one important thing, how the India runs with the strategies. Basically evidence-based treatment protocols are there. We are all having uninterrupted drugs and the logistics supply. Task sharing and the people-centered care is very important. Information system for the data entry is very important. This we are doing all very nice with the multi-sectoral coordination after the COVID. In the COVID, we have learned all these things. So capacity building with the human resources, this with all the nurses, doctors and all the people. This is the health promotion using the talk approach, means the community is very important in this to reduce any mortality or the morbidity or creating the awareness for that. So women's groups, healthcare professionals, religious leaders and the safe motherhood committees with the regional district are very important. So how the system is delivering the health projects into the nation. So community level, I have already told you about the registration, infection, non-infectious, infectious diseases and the NCDs. It has to be community-based assessment checklist, and all this work is done by the ASHA workers and this thing. This is very important for doing the things. The role of ASHA and the ANM work is important for the community level activities, population of the enumeration, CBSE assessment at the community level, and mobilizing the community and aware and telling them to come forward for to come to the hospitals. Health facility activities, screening at the sub center is very important because we are measuring the BP, then RBS and all pap smears and all we are doing at the sub center, PSC, urban health centers, and I follow up and the referral. So it is very important whenever you are working into the community health center. Now the government has come up with the NCD clinic was established at the CSC for the cancer, diabetes, hypertension, cardiovascular diseases and strokes, and the screening, diagnosis and the management depends upon this. At the sub center also, this is very important about the awareness, screening of the diabetes, hypertension, and three common cancers: oral, breast, and the cervical, and referral of suspected cases at the PSC and at the rural center is very important, because these higher centers will give the dispensing for the prescribed medicines and for the this thing for the treatment. See, one important thing after in COVID has happened is that the teleconsultation services is very important. The person who is sitting at the city, they can diagnose, they can give the treatment. It is very important in that. So screening of the all these this I have already spoke about this. This is also health promotion, including the counseling, is very important. Then opportunistic screening is very important. At the age of the 30, if they are coming to us, you take the family history, everything for to them, diagnose it, do the screening test, and then if it is something is there, a perfect referral system has to be done. And there are public private partnership projects are there, that is also helping for us to come in the picture of this. So district hospital, what is the role of the district hospital is that all the high risk cases, it should come with the this thing, and with this the STEMIs are very important, and then trauma centers, they are working very nicely, then dialysis. So what it happens is that whenever the diagnosed cases or the screening cases, they should come up with that, and we should have a chemotherapy center, physiotherapy center, dialysis center, and ISC activities for the important oral health hygiene. So these are the things very important which is happening at the district hospital, and maintaining the electronic health records with the telecommunication. Then comes to the tertiary care center, where the urbanization and the highest apex corporates or the institutions are there, where all the complicated cases, they can come here and we can offer the services to them. So this is the pyramid. This is the medical college. It causes the mentoring of the district hospital, early diagnosis and management of the complicated cases, training of the health professionals, and the operational research. So these are the components where the institutes work, either maybe a government medical college or the corporate hospitals for that. So this I have been covered in that. So what are the national health policies? Around 2000, so every year after dependence, we have a 5-year plan is there. But in national health policy, it has worked in a 2017, which has been improved the health aspects in that. Then it has come as a comprehensive primary health care, healthcare, which has been very important in targeting or preventing the NCDs, which today contributed to 63% of the mortality of the India. So primary healthcare reduces the mortality and the morbidity, which is very important in this. Then focusing on the technology and the IT based solution in the healthcare, we have a Ayushman digital mission. Abha is there. So in that also, we can use the use of the AI, the digitalization, IT based sectors for improving the healthcare, how to dispense, how to distribute, how to collect the electronic data, and how to treat also with these things. So our NCDs, we have 73.07 crore beneficiaries, 11.72 crore Abha number, 7.53 crore patients which has been treated under treatment with the diabetes and the hypertension. We say that around 2030 we will be a big capital for the all NCDs. So the government is working on that. See, for the non-communicable diseases, screening and the management, so this is a very important thing. So at the village level, the ASHA works in that. Then comes to the ANM, where is the screening is there. The MO and the nurse at the PSC, they manage the simple cases. Then the specialist nurse, and at the district hospital, it goes through that. The admin is the one which manages the users and the facility accounts, and these are the program officials. So policy making is also getting the data from the right from the root of this village, and it is coming to here. So this is a very good network in India, but most of the private people, they don't aware of this thing. So I have put in that. We have the apps like NCD portals, Asha mobile app, then HWC app, PSC web portal app also for the screening, diagnosis, and you can feeding the data in that. And then there is an admin portal is app, and there is a health officials dashboard. All these apps are very important when one of the organization or the any programs is there that is working and the data is being kept recorded in this. In the COVID, we have seen we have done a very good work, and we have eliminated the most of the, as good as eliminated the smallpox and the polio and the infectious disease. We are coming with the even control with the tuberculosis, and also for that this is very important in this. So these are the apps in that. Now, the clinical decision integrated patient pathway. So whenever the patients walks in, it comes with the examination details, the print recommended action for the MO, then whether you have to accept it or you can refer it in that. Updates the patient record and the patients walks out with the prescription. This is how we are supposed to dispense or the deliver the health system or the health, what you can say, help to the society in that. So there are various programs in that. Population based screening program is that with the common NCDs, with you have a Ayushman Bharat is there, then sub health centers and the wellness centers are there. This is also very popular. Then comes to the joint TB and the collaborative activities. With the tuberculosis, there is a reduction of the immunity. With the diabetes, there is a flaring of the infection. So you have to linkage, there has to be a referral linkage and integration of the system in the government of India, and it is working very well. National program for the palliative care, this is also a very good program with that. Then third is the integration with the National Urban Health Mission, the national program for the healthcare elderly above the 60 years of the age. The program aims to provide the accessible, affordable, high quality, a long-term, comprehensive, dedicated care systems to the aging population. Then comes to the 15th Finance Commission. Of course, without finance, nothing happens. So the budget also has to be kept in that. Then comes to the Ayushman Bharat Pradhan Mantri Yojana for the infrastructure. Now, with most of the government hospitals also has the modular OTs, very good tables, the endoscopies, even we have robots also in that. So the system is getting activated right from the infrastructure to the human resources, and even for the preventive aspects of the health system in that. Then comes to the Pradhan Mantri Jan Arogya Yojana. We know that for the poor people, 5 lakh cover for the family, and around 10.74 crore beneficiary families are provided till now in that. Then comes to the Ayushman Bharat, NDHM project, Government of India, creating the digital health records. Then we have the blueprints also, and digital electronic health records are very important in that. The Aadhaar number is a hassle-free method for accessing and sharing the records digitally. It's working. We have also, promoting it for the patients. Then, because if the patient goes to somewhere else, all the documents, whatever his lab reports, prescription, and diagnosis is there, they can access with this Aadhaar number. That is consent of that. Okay. राष्ट्रीय बाल स्वस्थ कार्यक्रम and the Rashtriya Kishore Swasth Karyakram. Then we have anemia prophylaxis. We have to reduce the maternal mortality. There are all the things are there. This is very important. The e-Sanjeevani National Tele-Consultation Service from the Ministry of the Health and all this. So e-Sanjeevani is based on the hub and spoke model. Hub is between the patient and the e-Sanjeevani hub is in between the doctor and the specialist, and for the e-Sanjeevani OPD, it is between the patient to doctor. So with telecommunication, at least a person who is sitting at the district hospital, if he has any issues are there, then he can consult with this thing. Yeah, at the OPD basis, even with the patients also, they can ask about the if he has any problem with the health. Then the Pradhan Mantri Bharatiya Jana Aushadhi Pariyojana, that we know that this is the AMRIT, because affordable medicines and the reliable implants for the treatment is very important. Now the stent prices, they have fixed the government stent prices, ortho implants are there, and all these equipments, the government is looking very stringently on it so that it will be affordable to all the people, and even the poorest one and the patient from the remote area try to access the health system or the health help whenever it is being needed in that. Then this is the Rashtriya Arogya Nidhi, around 15 lakhs to poor patients belonging to the families living at the below poverty line. Then Health Minister's Cancer Pension Fund. We have a very nice, even Chief Minister Fund is there, and there we have one nicely open the in Maharashtra, where we have one office and center, and there they are giving all these for the diseases, they are giving the money for the poor and the needy ones in that. So these are the just enlist in that national mental health program, prevention of control of deafness, blindness, fluorosis, healthcare of the elderly, tobacco control and the drug addiction treatment, then national oral health program, then program for the prevention of management of trauma and the burn, organ transplant program, palliative care program, and the iodine deficiency program. So all these are the incorporated. Just 2-3 slides about this. The risk factor that we have seen about the, if there is a behavioral, madam has said very nicely in that. Then physiological risk is that, then secondary prevention, diagnosis and treatment. And whenever established problem is there, then you can take the treatment with the expertise. This is just a 1 minute for the oral cancer also. We are doing a screening, and this is for the community based for the CA cervix. We can doing it for the pap smear and the VIA also at the community based in that. So supervision, monitoring and the evaluation is very important in that. It is not only the all the schemes, it should not be on the paper, but it has to go at the community level to the apex level in that. So the hidden non-communicable diseases is the one, mental health. Madam has already talked on this, postpartum depression. So screening, diagnosis and treatment is very important. The opportunistic screening is very important. Then urban slum population, the local government and the municipalities, they are doing it. Screening at the school children is also they are doing it, and screening and referring is the one important thing. This I have been collected this. So what are the countries where in the world they are doing with the NCD program is right from all the developed countries. First they have all these programs, and now it is coming to the developing countries. The matter is they are supposed to give with the budgets in that. So Maharashtra Cancer Warriors is that we have been collaborated with the Tata Memorial Centers, and all the chemotherapy, radiations, cancer diagnosis van. It is also being done at the state level, and even with the this thing. STEMI project is also with the Spoke and Hub. I have already spoken about this. Then it is, they have been this compiled with all this public and private partnership, and then they can use the facilities of the cardiologist with the cath lab and the cardiologist to reduce the to give the timely help for the cardiac cases. So national program for the prevention and control of cancer, diabetes, cardiovascular disease and stroke, and this is what we are aiming with this. So basically we are not having lots of many doctors with specialists and also how to deliver the system at the root level or tribal level. So integration with the Ayush doctors, this is the one of the things where you can take the help of them also whenever it is being needed in that. So health planners and the policy makers actions is very important. So whenever there is to organize the community for the education motivation, the strengthening the referral system is very important. Management of the protocols, it has to be very proper, and it has to be followed to all levels, that how to prevent the PPH or infection control and all this. And the periodic audit of the existing healthcare delivery system is very, very important. We have a maternal death audit and other death audits also. Then legislative and the policy actions. So where you should focus on that, the girl children and the adolescents, barriers to the access to healthcare facilities should be removed. One, decentralization of the services to make them available for all women. Safe abortion services, then social inequalities and the discrimination on the grounds of gender, age, and marital status and the economy has to be removed. So these are the legislative aspects of this. So what the WHO response says, by 2030 agenda is, I told you, the SDG target for NCD is around 3.4 cause, and the maternal mortality has to be reduced to 70 per 1 lakh. Around this thing, these are the recent guidelines which I have referred from 2023 to around focusing on a 2030 in that. This is just for this, how we are getting decline in that. With this, the steps of reduction, we know all that. I have not concert in that. So I don't know what's the time is there. And ounce of prevention worth a pound of cure. That is what how I would like to end my talk in that, because the prevention is the better, but even at the government level and the community level, we are also part of the society, and we are at the part of the government also. In the private sector, there is no differentiation. Like what you can say is that there is a government and the private sector, because everything is at the end is combined, what we have seen in the COVID also in that. Because even with the private sector also, you have to take the registration, everything, all the permissions, and also all of the doctors, all of the gynecologists, all they have done a lots of good work. That's why it is the base effect that we have reduced the maternal mortality in most of the things. Even the Kerala, Maharashtra is below 70 in that, and we are working with the UP, Assam, and all this. So it's not a only one work of the government, but it is all, we are all one only in that. So I think Government of India, Health Ministry, and everybody is doing very good in that. I don't know the time, but thank you, Kanchan ma'am, Parag sir,
Thank
Shri
you.
sir,
It was
and
wonderful, wonderful talk.
it was a
Actually,
very
we all
weird talk. I
need
just tried
your
to
PPTs because
simplify
a
it.
lot much very important and interesting information do we have
Yes.
it. So
Very
Thank
true,
you,
ma'am.
Rajashri.
over to Sheila
Uh,
Excellent.
Mani,
Thank
madam.
you.
Excellent. I mean, uh, all of us have to really learn that how much government is doing. And if there is a PPP model for everything,
Yes, 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 yes.
public private partnership.
Partnership.
Yeah.
Ma'am,
And
I
I
would
think
like to
more often, more.
on this platform, I would like to say that the ICMR has come up with to save the lives in the golden hour. So they have conducted the these all projects at the 6 states in that, and it is getting a very good response. They have included PPH in the gynac, STEMI, trauma is there, snake bite is there, and fortunately I have been chosen as an expert from on the gynac thing.
Congratulations.
So with me, Dr.
Mm.
AG
So nice.
is there.
Thank
And
you.
Very nice. We
Thank you.
came to know about your work and whatever you have achieved. When I was reading, I was not able to read your whole, but so much, as well as academics. And hats off to you, Rajeshri.
I'm
And proud to be associated with you. And more work. I would like you to
we
come
will.
forward for ICOG also. We all will work together.
Ma'am would
Okay.
like to
Thank
add.
you.
Chalo. Thank you. Thank you.
Uh,
Everyone. Thank you.
Now
thank you
we
so much,
have
ma'am.
two
Uh,
speakers.
th-
First of all, I want to thank Parag sir. Dr. Parag has very kindly consented to speak on the topic which Dr. Girjawag was talking, and the other is Dr. Sheila Mane, Dr. Shubha Gude. So, Seema?
Yes, ma'am. We are very grateful to Parag sir, and we are fortunate to have him for our next talk on hypertensive diseases of pregnancy. I would like Sheila ma'am to kindly
No,
introduce Parag
don't
sir,
waste
who
time
know
in
he doesn't
introducing
need
me.
any
अरे नहीं सर,
introduction.
करना
But
चाहिए.
sir, the formality.
No. Forget the formality
Uh,
because we are already
uh,
little late, and
uh,
people have to go back to their work. So
uh,
let's not waste time in that.
thank you so much, sir. Thank you
Right.
so much.
Yeah. All right. So in 15 minutes, I'll try to cover a big topic of hypertensive disorders in pregnancy, and I'm happy that Dr. Suchitra Pandit, who has led the Gestosis India for a very long time, is here to listen to the presentation. Uh, Hypertension, we know, is one of the most common medical disorders in pregnancy, and it is really important for us because these are the women who are likely to get into the NCDs as they grow older. So we know that it complicates around 7 to 10% of pregnancies. And of course, the classification is something which we all are aware about. Why we should be concerned about preeclampsia and eclampsia is because of its contribution to maternal death. Let's not forget that eclampsia is something which is definitely preventable. We may or may not be able to prevent preeclampsia, but we can certainly do our bit to prevent a death. Uh, the good news is that the maternal mortality is on decline, and luckily in Maharashtra, we are much better off than so many other states. The WHO also has uh, declared the theme for the year 2025, healthy beginnings and hopeful futures. And they also emphasized about various conditions, which definitely includes hypertensive disorders in pregnancy. We all are aware what exactly preeclampsia is, and but it is this preeclampsia with severe features, which is something which we all should be wary of, because here the the bodily functions go for a toss. There could be an impaired hepatic function. There is progressive renal insufficiency. There could be cerebral or visual disturbances and pulmonary edema, not to forget thrombocytopenia, which all add to the misery of a woman who's pregnant. We know the incidence of preeclampsia is around 2 to 8%. Amongst all cases of preeclampsia, 10% occur in younger women. The global incidence, of course, is much higher than what we expect. Why we should be concerned about this particular condition? Because it is going to practically harm all the organs in the body, and they then end up into various non-communicable diseases. We also should be wary about the morbidity and mortality in preeclampsia, eclampsia. It is because of systemic vascular endothelial dysfunction, vasospasm, CNS events such as stroke, hemorrhage, etc., acute tubular necrosis, and coagulopathies. So it is really important that we do uh, what we can, that is predict the conditions. There are so many risk factors which are postulated to be associated with hypertensive disorders of pregnancy. Nullipara, women more than 40, pregnancy interval more than 10 years, pre-existing vascular disease, pre-existing kidney disease, they all are thought to be associated with the risk of hypertension in pregnancy. So rather than only talking about the rationale, we should understand that selecting appropriate patients for initiation of low dose aspirin is important, because here we are able to prevent preterm preeclampsia. And of course, we also get an opportunity to refer these patients for a higher center for a specialist care. So when we talk about strategies, there are two folds that we should look at. First is historic and demographic risk factors, and of course, then there are multi-test and computational risk prediction models. All organizations like ACOG, NICE, SMFF, FIGO, etc., have talked about various historic and demographic risk factors, but what is very important and relevant for us in India is the gestosis score, which was proposed during the FOGSI ICOG gestosis GCPR in 2019. And then this is something which is so simple to understand and to execute. There are certain risk factors which are given a score of 1. There are certain risk factors which receive a score of 2 or 3, and any woman who has a score of more than 3 is at risk of developing preeclampsia, and she's the one who should receive aspirin as a preventive therapy. So many medical colleges have taken up gestosis score as a project, and there, I'm happy to say that a lot of studies have validated its use, and now all of us should be proud that we have contributed something to the women's health as far as our country is concerned. Of course, there are other factors like PLGF. We know that individuals who develop preterm preeclampsia have significantly levels of PLGF. Significant association exists between lower serum PLGF levels in pregnancy and severity of preeclampsia. Of course, this is something which we don't use alone. We uh, always use it with other anti-angiogenic factors like the SFLT1. S-flat1 is not measured as a standalone, but it is the ratio of S-flat1 and PLGF which predicts preeclampsia. Of course, these are the tests which are of the future. They are not readily available everywhere. They are not cost effective as such. And currently, there is insufficient evidence. But in the years to come, probably we'll get to learn about these biochemical markers much more. The Fetal Medicine Foundation has come up with a calculator for 11 to 14 weeks. Now, here there are certain maternal characteristics which are taken into account. The biophysical measurements like mean uterine artery pulsatility index and or MAP is considered, and PLGF is the ideal biomarker. But if not, we can always look at the pregnancy associated plasma protein A or PAP-A, which definitely has a good utility. And here, the detection rate is definitely good, and we are able to detect a preeclampsia, a preterm preeclampsia in less than 32 weeks in almost 90%. Let's understand that this is one situation which has to be looked at very, very critically, because in a woman who's less than 32 weeks and who has preeclampsia, we are always concerned about continuation of pregnancy as well as the outcome of the pregnancy. After predicting, it is important that we prevent preeclampsia. There are so many pharmacological drugs, dietary interventions, and lifestyle modifications which were described. This is a list which Suchitra will definitely recognize this slide, which we had taken in the hypertensive disorders course, which we had publicized during your FOGSI presidential tenure. And now we know that all these lifestyle interventions have no evidence to support. So there's no role for complete bed rest, no role for salt restriction, or even no role for energy and protein intake. Nitric oxide donors, some papers have stated that they are useful. Of course, there are certain positive effects that we get to see when we are using nitric oxide donors, but currently there is insufficient evidence to recommend it. Calcium is something which is a simple intervention which all of us can do, especially if the calcium intake is low. We can ask the woman to take at least 1 gram of calcium, and this certainly reduces the risk of hypertensive disorders of pregnancy. Of course, people have tried antioxidants, various vitamins, fish oils, magnesium, etc., but currently the evidence is insufficient. So is true with low molecular weight heparin, antihypertensives as a preventive measure for development of preeclampsia, progesterone, and diuretics. All have not proven benefit to women who later on are likely to develop preeclampsia. The only molecule which has been tried, tested, and proven is aspirin, and we know that here it not only makes the outcome better, but then we also know that the chances of preterm birth or growth restriction are also reduced when we put women on aspirin. And then there are so many studies which talk about its efficacy. There is reduction in proteinuric preeclampsia, reduction in fetal or neonatal death, reduction in overall preterm births, reduction in small for gestational age newborns, and in general, reduction in composite serious adverse maternal and neonatal outcomes in women. When do we start it? The best time probably to start it at around 12 weeks. FIGO recommends to start it between 11 to 14 weeks. There's always a question mark about the first trimester, when we believe that aspirin may not be safe in the first trimester, but we know now that it can be continued, especially if the woman is already taking it. The thing that is not there's no consensus about the dose, and then there are various studies which have given doses. Most of us are using 75, though the aspirate trial recommends a dose of 150 milligrams per day. The important points to be noted: the American Cardiology Society suggests that it is more effective if it is taken to bedtime. As far as discontinuation is concerned, there was a time when we discontinued it at around 36 weeks. Then came some studies which said that it can be discontinued 5 to 10 days before the EDD. But now the current concept is that we can continue it even when the patient goes in labor. And the Aspirio trial is something which talks about role of aspirin, 162 milligram versus 81 milligrams, especially in women who are obese. And As far as safety is concerned, we all are aware about its safety, though there is a possible theoretical risk of PPH, but we know that it does not really harm the mother as well as the fetus. And the third part is treatment, that is how to protect women who have preeclampsia. And here we have to understand that the warning signs are something which we should be aware about, because when a woman comes to us with these warning symptoms and has high blood pressure, we really have to act fast in order to prevent the challenges. The laboratory investigations, we know that hemogram PBS should be done to rule out hemolysis and thrombocytopenia. We would do a coagulation profile, LFTs, RFTs, and we must document albuminuria by urine examination. So the surveillance of the fetus is extremely important, and we can do that by biometry, by doing amniotic fluid volume, and of course by doing a Doppler study. But women who are more critical, we must take help of our radiologist colleague to have a maternal USG, where we would like to scan the liver, kidneys in detail to rule out the complications arising out of hypertension, which is of severe nature. And 2D echocardiography of the mother is really important uh, tool when we are managing these women in the antenatal period. Coming to the medical management, and these are the recommendations of FOGSI ICOG, Gestosis GCPR, labetalol, and nifedipine are the drugs which all of us have been using. Most of us have used methyl dopa in the past, but we know that it is now not easily available. For women who have severe preeclampsia, where we would like to control their blood pressure rather rapidly, please note sublingual nifedipine is a strict no-no. Injectable labetalol does work well. Hydralazine has its own place in the management. Coming to the birthing decision, and this is a complicated slide, but the FOGSI ICOG Gestosis guidelines do talk about these simple points which must be taken home. If we are dealing with a woman who has gestational hypertension, we can continue the pregnancy till term. Mild preeclampsia, consider delivery at 37 weeks. Of course, here we have to take into account all the factors. Severe preeclampsia, we should try and continue till about 34 weeks. But if the blood pressure is not controlled, if the mother's situation is worsening, we would certainly deliver her much earlier if needed. And of course, eclampsia, stabilize the mother before delivering her. The intrapartum management is extremely important. So it is prudent that the woman delivers at a well-equipped birthing center with senior obstetricians around and a backup of critical care units, blood bank, and anesthesiologist and neonatologist, if needed, transfer facility. Mode of delivery depends on urgency to deliver, Bishop score, gestational age, Doppler study findings, and severity of fetal growth restriction. But in general, studies have stated that labor induction was associated with a reduction in maternal morbidity and a trend towards reduced neonatal morbidity. So we should make an effort to try and deliver these women vaginally. So induction of labor can be done with the help of prostaglandins. We have the gel, suppositories, and misoprostol um, at our disposal. Mechanical dilatation is important. So we can certainly use Foley's and augmentation of labor needs to be done with oxytocin. Uh, Monitoring during birthing is also important. A labor care guide is a good tool for monitoring. Electronic fetal monitoring is definitely preferred. We should try and offer labor analgesia to women and using vacuum and forceps wherever indicated. Third stage has to be managed actively, and you can practically use whatever you have, may it be oxytocin, misoprostol, or even carbetocin. But preventing PPH is extremely important, and so is preventing seizure, where Maxim definitely scores over the others. The management has to continue even in the postpartum period, and we have to monitor these women, because this is the time where the NCDs are around, because she's the woman who's then later on likely to develop cardiac conditions, hypertension, and all sorts of complications because of chronic hypertension. So to conclude, the antenatal risk assessment is of great help. Aspirin at around 12 weeks, something which is really important. Calcium intake in low calcium group. Gestosis score appears to be a very simple and useful tool for prevention of preeclampsia, and prompt initiation of treatment, referral to higher centers are key interventions for management. So I would conclude by these two sentences. Preeclampsia may not be preventable, but eclampsia is. So we should not let any pre-eclamptic woman to convulse, and let's all pledge that no mother should die of hypertensive disorders of pregnancy. So thank you very much, and thank you, Dr.
Excellent.
Kanchan, for
Excellent.
having me here today.
Thank you.
Nice talk.
This is the expert that you have taken at the 11th movement and told everything very nicely with the perfection.
No,
So many hearts and
I'm
claps.
dedicating this lecture to Suchitra, because Suchitra, when she was president of Gestosis India and I was secretary of ICOG, so that is the time we in fact initiated these GCPR, which now I'm happy to say that next month we are going to revise those, and in 2026 we should come up with a new recommendations. Thank you.
Just if I may just say, Parag, this study between low dose aspirin 75 versus 150 is going on at Safdarjung Hospital. Upma Mishra is doing it, and hopefully by the end of 26 we should get out some results, so we'll know what is better. And the ISSHP, the recent paper says that those 75 is accepted because it has got lower problems, lesser amount of problems. But when the BMI of the woman crosses 35, probably a higher dose. But again, they've mentioned probably higher dose awaiting trials. And second thing, which I just wanted to mention now, we've got, we've actually now we'll be revising this, of course, in our guidelines, the mild and they've said, don't say mild and severe, just say preeclampsia. We, for sakes of convenience, we say non-severe and severe, but the ISSP says just don't have any of that, just change the classification, which will be changing very shortly. And third is WHO has come out with a very promising test, which is the Congo Red test. And they have tried it out in Dhaka and Mexico. And it is a simple test where the pregnancy of preeclamptic women who are going to develop preeclampsia, that has got some amyloid fibrils. If you add the Congo Red dye to that, it will turn red. So which means that this woman is going to get preeclampsia. So even the ASHA workers can do this particular thing. And hopefully they're trying to scale it up. And, maybe by next year, we should be able to get that test also. But I'm very happy to say that I'm glad that so many people have taken up the Gestosis score for in their medical colleges. But please put it into your daily practice. And Gestosis score, Gorak has very beautifully, he mentions that it's not just the first visit. At every trimester, every visit, you can use it. It's a dynamic score because at 20 till 24 weeks, you can add on EcoSprint. But the best is, of course, when you add it, as Dr. Parag said, very early, the sooner the better. But supposing after 26 weeks, you get a Gestosis score of say 13 or 14, you know that this is a high-risk patient and needs to go to the high-risk center, more vigilant monitoring, maternal and visual. So simple things which we can use at our setups. So that is the beauty of this. And please, lots and lots of people should start using it.
Yeah,
And thank you, Parag, for
now,
taking this up
now
so
they
well.
have made compulsory with the state of Maharashtra guidelines has come with that.
Yes.
So there were 4 HODs. So in that I was also a part of making their this PPH. Then this is for this, and using of the steroids for the premature
Yes,
preterm.
and I think
Yeah, we have included
also
Suchitra.
convinced Karnataka
We have
government. Yeah,
we have
I know.
included it in the
Yes, Karnataka
card,
government.
antenatal card.
Yes,
So
yes.
everybody knows now. We did the certification course for all the government doctors, and it is included now.
And recently at Pune, when Dr. Pavan Kumar was there for my talk, I requested him also. I said, sir, I request you to please include in the government, the central government, let it come through. So let's see. Things are changing. What we want this to be, it's easy. It's nothing complicated.
Yeah.
State has included, Madam Suchitra ma'am. State has come up with this.
No, state has come. I'm talking about the central.
No,
Center.
center also, Government of India giving the guidelines for the low dose aspirin also.
No, but they've not talked about the
Justice
justice
score.
score.
We are talking about
Acha,
justice score.
justice
I
score.
am talking about justice code.
They
And
will,
even
they might
Frank Lowen in FIGO, I said, sir, you're talking only about PPH at all levels. But for our country, we have controlled PPH. We are pretty good. But now for us to come down from that low level to further low level, we have to look at HDP. We cannot ignore HDP anymore. I see Vidya Tobi also come in.
Yes, ma'am is there.
Hello. Thank you, Parag. Nicely
Acha
done.
ho gaya, Parag
Thank you.
sir. It was very good talk.
Thank
Very
you.
informative.
I think
Thank you so much,
thank you
sir.
very much. And Dr. Shobha Gudi was there to join, but now just now she rang that now I am boarding. So, and so actually, with the vote of thanks, vote of
Yes.
on behalf on behalf of FOGSI and ICOG, I extend my heartfelt gratitude to everyone who made today's masterclass on the women's health and non-communicable diseases so enriching and meaningful. My deepest thanks to our dynamic FOGSI president, Dr. Sunita Tendulkar. In spite of being so busy in Delhi conference, she joined and blessed us. Her inspiring leadership and constant encouragement guide us all. A special thank you to our esteemed ICOG chairperson, Dr. Parag Binwale sir, for his wholeheartedly support. Even at the 11th hour, he took very nice lecture and his ever supportive presence. Dr. Sarita Bhalerao, our ICOG secretary, whose sincere efforts and the genius advice always does wonders. My warm appreciation to Dr. Sheila Mane Madam, our ICOG chair-elect, and her wisdom, her calm strength, and her exceptional contribution for women's health. I express my sincere gratitude to the persons Professor Ashok Kumar, although he could not join, Dr. Suvarna Madam could not join, for their always guidance and continuous encouragement. A big thank you to our brilliant speakers who shared knowledge with such clarity and depth, enriching every session for reproductive health to NCT related strategies. Special thanks to Suchitra Madam, to Professor Dr. Rashri Katke, who is still there and logged in. My sincere thanks and regards. My heartfelt thanks to our wonderful coordinators, Dr. Seema Divedi and Dr. Jupirika, for their efficiency and dedication that made this program flow smoothly. A special mention of gratitude to Nilima from ICOG office, who's behind the scene coordination ensures flawless execution, and to Shreya for her excellence technical support that kept the entire masterclass running seamlessly. To all the chairpersons and the moderators, your expertise elevated today's academic discussion. And finally, my gratitude to every delegate who joined us this evening. Your active participation, enthusiasm, and engagement made this session truly meaningful. Thank you all for being a part of this academic journey. Together, let us continue to strengthen women's health across the India. Thanks a lot in regards.
Thank you.
Thank you, Dr. Kanchan and team, and congratulations for the successful conduct of this program. Thank you.
Thank you so much, sir. Thank
Parag,
you so
with your
much.
permission, can I make an announcement,
Yes,
please?
please. Yes, please.
On the 19th of December, Dr. Parag and Dr. Sarita have given us permission to hold a masterclass on youth issues. So let's do it together for the youth. And we're doing it along with the Adolescent Health Committee. We will send the brochure very soon. So please encourage all your younger people also to join. your postgraduates, whoever is attached to medical colleges and institutes, and your DNB students, because it is meant for the young people, but for us as seniors to, mentor them in a little better way. Thank you so much, Parag and Sarita.
Thank you.
Thank you,
Bye bye.
Sarita.
Good night.
Thank you,
Bye.
sir.
Good night.
Good
Thank
night.
you, Kanchan.